commissioners, and to everyone listening and watching us. So we have back-to-back meetings this morning between the MOAT committee and the CDT committee. And in addition to being back-to-back, there's also a part which is going to overlap, which is a presentation that we're going to have on upcoding and upcoding practices. And so I'm going to try in the first, that part is going to happen at 10:30, but we have quite a number of things to do in the interim. So I'm going to try to keep us on at least close to the time. But I don't want to foreclose people having comments, because we actually have a couple of super fascinating presentations and issues to discuss. So the things that we're going to do first, before we get to the upcoding discussion, we'll first see if we approve the minutes. And then we have a data points on urgent care utilization in Massachusetts, and then hear more about COVID-19, and in this case, the impact on ambulatory care, as we try and make sense of what's going on with the healthcare system. So I think the first item for us is to approve, if we so choose, the minutes from the February 9th meeting, which was our previous meeting. So let me ask first if there's a motion to approve them.
Motion to approve.
Okay, Patty, thank you. And then is there a second to the motion? Okay, second, thank you. And then Colleen, I think I need to turn it over to you because we have to do a roll call.
Exactly right. Okay, we'll start with you, Chair Cutler.
Approve.
Commissioner Mastrogiovanni.
Approve.
Commissioner Haupt.
Approve.
And Commissioner Roeder.
Approve.
Okay, thank you.
And Tim had not been at our previous meeting, and so that's why you didn't call
Exactly.
Tim for that. Okay. Good. So that's approved. So now we want to turn to the issue of urgent care utilization in Massachusetts. And what I'm going to do is I'm going to turn it over to David Seltz, say good morning to David. And I hope you're doing well, and take it over from here.
Good morning, commissioners. Good morning, Professor Cutler. I am doing well. Really excited for this morning. A lot to discuss and to present on. And really want to begin the first hour here with showcasing some brand new research from our research team, building off of past work, but really having some new data, some new information, some new findings. And so I'm going to turn it right over to the presenters here. And so for our presentation on urgent care utilization, Sarah Sadownik is going to lead us through these findings. And as Professor Cutler said, do really encourage questions, discussion, and your perspectives as well on this important work. So Sarah, take it away.
Great. Good morning, everyone. We're really pleased to present our results today. And I first want to thank the other contributors to this work on my team, Dhruv Mandalia, Yua Huang, and Diana Vascones. So thank you to them. So this work that we're presenting today follows from earlier work that we did on this subject for a data points that we released in 2018. And as a recap, that earlier work had found that the number of urgent care centers and retail clinics had grown dramatically in the years since 2010. And we found that visit costs and patient cost sharing varied substantially by site of care, with higher costs at emergency departments. And we also found that both retail clinics and urgent care centers were disproportionately located in higher income areas. So our work that we will be releasing in a data points later this spring and present preliminary findings on today, followed up on these topics and others, tracking the growth in these centers, change in the community income of their locations, costs and services offered during the pandemic. And the pandemic context is certainly a critical one for this work. Next slide, please. So we We followed up on our earlier work with a survey of urgent care centers and retail clinics in Massachusetts that was conducted in late 2021 that collected information on location, hours, and services, among other data points. And we want to acknowledge our contractor, MHQP, that assisted in conducting that survey. That was a survey of sites that were open in 2021. We also tried to estimate closures of sites that had occurred in recent years. We also supplemented that work with analysis from the all payer claims database that went through 2020 data. So to create sort of groupings of all of these many centers for urgent care centers, we created 3 groups. One, centers that are affiliated with major health systems. A second, centers that are affiliated with large chains, that could be national or regional chains that we defined as having at least 3 urgent care centers in Massachusetts, and sort of an other catch-all, which is mostly independent urgent care centers, also includes some centers that are affiliated with community health centers and a few others. Next slide, please. So let's talk about some definitions for what these sites are. Retail clinics are, they are licensed in Massachusetts as limited service clinics. And that means they're typically staffed by nurse practitioners. They're located within large pharmacy chains, and they provide a limited scope of care. All of the retail clinics in Massachusetts are CVS Minute clinics. In contrast, urgent care centers usually include physicians on staff, in addition to nurse practitioners and other providers. They provide diagnosis and treatment for more pressing and somewhat more complex conditions, often offering imaging such as x-rays for broken bones. But these are somewhat more complex conditions, but these are not life-threatening conditions. Next slide. So this graph shows the total number of urgent care centers and retail clinics in Massachusetts from 2010 to 2021. We see that the total number of urgent care centers grew from 15 in 2010 to 173 in 2021. And the number of retail clinics grew from 20 in 2010 to 59 in 2021. While the number of retail clinics has remained at 59, in fact, since 2018, the total number of urgent care centers in Massachusetts has grown each year, up from 143 in 2018 to, again, 173 in late 2021. Next slide. This graph shows the number of new urgent care centers and retail clinics that entered the market each year. We see that for urgent care centers, the number of new centers that opened peaked in 2017 with 29 that opened in that year, but new entry has continued each year for urgent care centers. For retail clinics, again, the number of retail clinics has remained at 59 since 2018. Next slide. This graph shows the total number of urgent care centers since 2010, broken into major centers that are affiliated with major health systems, centers affiliated with large chains, and that sort of other mostly independent group. By 2021, almost half, or 45%, of urgent care centers were sites that were operated by major health systems. About a third, 36%, were part of large chains, such as Carewell, Convenient MD, and 18%, minority, were independent or sort of other affiliations. That's a change from earlier years where independent centers represented a much larger share of the market, such as in 2014, those represented a third of the market. But since then, both sort of entry from larger chains and major health systems outpaced growth in sort of independent centers, and a larger share of independent centers have closed in recent years. And I should note that the sort of the growth in large chains in recent years is driven by the entry of Convenient MD, in the Massachusetts market since 2018 with 12 new centers. Next slide. Thank you. So this shows the urgent care centers by ownership for centers with at least 3 sites. So you can see the breakdown here. I should note also that pediatrics on the right with 3 have all entered in recent years since 2017. And of course, as a reminder, all of the retail clinics in Massachusetts are part of CVS Minute Clinics. Next slide. This gets into, this slide starts to get into sort of the geographic and other factors of distribution in Massachusetts. We see the growth in urgent care centers, retail clinics, and EDs from 2013 on the left to 2021 on the right. And we see that that urgent care centers in particular have grown in number and geographic diversity in Massachusetts over these years. That's the blue dot. This shows the number of urgent care centers per resident across Massachusetts, and we do see quite a bit of variation from 4.8 urgent care centers per 100,000 residents in Metro West to 0.7 per 100,000 residents in Fall River below that. I do want to emphasize that this is only one type of care. This isn't a measure of sort of full access to care. It doesn't account for access to physician offices or retail clinics for that matter, or EDs. So it's not the full story, but it is it is a snapshot of this important type of care. Next slide. Now we're getting into distribution by income in Massachusetts, and we see that both urgent care centers and retail clinics are disproportionately located in higher income areas of Massachusetts. These graphs show the distribution by income quintile of the zip code of the site. And if we look on the 2 darkest bars there reflect the highest 40% of zip codes by income. And we see for retail clinics, 55% are located in those highest income areas, and 50% of urgent care centers are located in those 2 highest income areas of the state. That's the graph on the left. On the right, this is the distribution by income of urgent care centers that have opened just since 2019. And we see that, in fact, that sort of overall average on the left is somewhat driven by new entrants. We see 63% of urgent care centers have opened in higher income areas just since 2019. Next slide. This graph shows the percent of urgent care centers by ownership that are in the 2 highest income areas of the state. And we see that there is quite a bit of variation in where these different groups by ownership have located. We see that among large chains and major health systems, they have quite a large variation in where they've located by income. Some are predominantly located in lower income areas. For example, all of MedExpress, all the urgent care centers associated with MedExpress are in, or I should say none of them are in the 2 highest income areas. And only 17% of South Coast urgent care centers are located in the top income areas. However, overall, we do see that large chains and major health systems are disproportionately located in higher income areas. We do see that, in contrast, independent urgent care centers in that orange bar are less likely to be located in higher income areas. Only 1/3 of them And I do just want to point out that this graph shows centers that have at least, or I should say groups by ownership that have at least 4 centers. PM Pediatrics, which has only 3 centers, is not included on this graph, but all of them are in higher income areas. And I'm just making a note of that since sort of access to sort of specialty services for children has been, you know, an area of increased focus, especially during the pandemic. Okay, next slide, please. This graph turns to shift in care during the pandemic. This is the number of E&M visits per 1,000 member months by the type of site for commercially insured patients. Between 2018 and 2020, we're particularly interested in the change between 2019 in the orange and 2020 in the gold. And we see that between these years, fewer E&M visits occurred in the office, HOPD and ED settings, while more occurred in telehealth, of course, and shifts also occurred in urgent care from 18 E&M visits per 1,000 member months to 19 in 2020. That's the average among commercially insured patients. Next slide. So we wanted to get under the hood of those average numbers, and so here we look at shifts in site of care by income of the community, by patient income, and we see that that between 2019 and 2020, that growth in use of urgent care centers was concentrated entirely among residents in the highest income areas, and particularly the highest income, 20% change in number of E&M visits per 1,000 member months. What's really interesting is that the visit rates in 2019 were actually pretty similar in the lowest and highest income areas. It was 15 versus 16 visits per 1,000 member months in 2019. But that visit rate really increased among the highest group, so increasing to 19 visits per 1,000 member months in 2020. And again, this is just among commercial patients. So there, you know, these trends could be due to a number of different factors. You know, just some ideas on this are, it may be that for patients living in the highest income areas, maybe they, during 2020, they started using urgent cares for different things than their counterparts in lower income areas. Maybe they were more likely to go for COVID-19 testing. We have found in previous research here that that people with higher incomes are more, say they're more likely to use urgent cares because they're more confident that they're not going to get charged for a large unexpected bill. And so, you know, it's possible that sort of among potential new clients to urgent care or people who are seeking to use it for different things, they have more confidence that in that their benefit design, that they wouldn't get charged for an unexpected bill. We've also seen in previous results that we showed here today that higher income people are more likely to live near an urgent care center. That may have been a factor. So again, more research is needed in this area, but it's an important finding. And while these results are among commercial patients, I do really want to highlight an important policy change which is that in the Mass Health population, which is that starting in January 1st, 2021, Mass Health removed the requirement that patients needed a PCP referral to go to an urgent care center. That important change may increase incentives for urgent care centers to locate in lower income areas. So I guess sort of overall, these results show a real impetus to make sure that urgent care centers are available for all patients. Next slide, please. So now we're turning to services and hours. for urgent care centers and retail clinics. We found that urgent care centers do vary quite a bit in operating hours, but most are open outside of standard physician hours. For urgent care centers, the most common weekday hours, about half of centers were from 8 a.m. to 8 p.m. The most common Saturday operating hours on the right are also 8 a.m. to 8 p.m., but about a quarter of centers, and most have similar hours on Sundays. All the Minute clinics in Massachusetts have the same hours. Next slide. Thank you. This graph shows sort of special services that were asked about offered at urgent care centers in 2021, and most offered COVID-19 testing in addition to these common other services. Only 4% of urgent care centers reported not offering COVID-19 testing. There were sort of high rates of sort of non-response to some of these questions. So, and other common services offered are treatment for sports injuries, imaging, and sort of other specialty services. Next slide. Turning to spending, we show here average spending and cost sharing for low acuity visits by site of service. We want to focus on low acuity to have sort of a more apples to apples comparison. This graph shows that that average spending for a low acuity visit in an ED on the right is 7 times higher than in an urgent care center and 10 times higher than in a retail clinic. And cost sharing is 6 times higher at almost $200 in average cost sharing in an ED for a low acuity visit versus $32 or $33 in a retail or urgent care center, similar to office cost sharing. Growth over time also grew the most in EDs, with growing 34% per visit between 2018 and 2020. I want to point out that this analysis only reflects professional fees for urgent care centers. Some urgent care centers, in particular, some that are affiliated with major health systems, may also have facility fees that aren't reflected here, and we'll talk a little bit more about that later in the presentation. Next slide. This graph shows the distribution of spending for low acuity visits by site of service, and shows that the variation in spending for a low acuity visit in the ED is far greater than in other settings of care. The 25th to the 75th percentile varies in ED by almost 3 times, and the outliers of what someone's visit might cost are incredibly wide compared to much lower ranges in urgent care, retail, and office, and hospital outpatient departments are somewhere in the middle. Next slide. This graph also shows average spending per visit by site of care for some common conditions, common low acuity conditions among adults, and again, really illustrates the difference in what a visit might cost, for the same common low acuity condition, depending on where the patient goes for that care. Next slide. So now I want to get back to the point about how our spending numbers for urgent care centers only reflect professional fees, but there is some variation in how urgent care centers bill, and that variation exists only among urgent care centers that are affiliated with major health systems. So to describe this, I want to take a step back and maybe set the landscape for how different settings bill. For physician offices and retail clinics, they only bill professional claims. There's only a professional claim component by definition. Hospital outpatient departments and emergency departments, they have a professional claim and they have a facility fee claim. That's, this is the the facility that's for, overhead that is going to, sort of the, the everything that goes into a facility fee, of sort of the capacity for complex care, et cetera. Urgent care centers, there could be quite different systems depending on which urgent care center it is. Standalone chains and independent centers only bill professional claims. However, centers affiliated with major health systems, they bill the professional claim, but the professional claim might be billed as an urgent care center, it might be billed as a physician office, and some centers also bill a facility fee. And that facility fee may also appear to be a claim for a hospital outpatient department or an ED. This is probably the most confusing slide in the presentation today, and I want to go to the next one to give some examples that might help clarify this sort of complex topic. So this slide shows some examples of policies, and the goal here is not to single out these providers and payers that are listed here. These are just the ones that have provided some transparency about the policies in their website. So there's a lack of standardization in the billing practices that urgent care centers affiliated with major health systems use. On the left is from Mass General Hospital's website. This is saying, depending on which of our urgent care centers you use, you might be billed as a physician office, list of those. And for others, you might be billed as a hospital outpatient department visit, for the 3 that are listed there. And they note at the bottom that you might be billed for a facility fee. I see a question, how large are the facility fees? That can really vary. It could be from maybe $20 or $30 for the service to a few $100s. So there's the billing practices that a center has. It also, there's also a lack of standardization that's driven by payer rules. On the right, we see from Harvard Pilgrim's website, in fact, instructing urgent care centers to bill a E&M visit, to bill it as an emergency room visit. There's also sort of a lack of standardization in the licensure. There's not sort of crystal clear licensure like there is for retail clinics and some and other types of care. So not all urgent care centers are individually licensed. They may be licensed under a physician's medical license if they're independent physician owned, or they might be licensed, in fact, as satellites of a hospital. So there are some really important implications of this lack of standardization. There's implications for research and accountability. It's from our perspective in doing this research, it's quite difficult to find these facility fees because, in fact, they are listed as they might be listed as EDs or hospital outpatient visits. So that results in, potentially an undercount of visits and importantly, a potential undercount in spending per visit for certain centers. And most importantly, it has important implications for patients. A patient may choose to visit an urgent care center instead of an ED, but unexpectedly receive the same bill that they would have received at an ED when they're doing everything right. This is an important dynamic that we wanted to highlight today. And then the last slide, in conclusion, this summarizes our points from the presentation today on growth in centers, location and disproportionality by income, spending, and emphasizing an opportunity for greater standardization to increase both transparency and patient protections. So I'll conclude the presentation here and welcome any questions.
Sarah, that was fantastic. Thank you. That was a lot of information. I see, Stuart, it's wonderful to see you. I saw your picture. Now I can't seem to find it, but
He's here.
I'm here.
got it. Great to see you. Great to see you. I have Marty, then Patty, and then Dawn. So why don't we go in that order?
Thanks, David. Sarah, great data. Thank you. Wonderful presentation. I have two questions. One, I remember years ago at one of the cost trends hearings, we heard from CVS Health. And at that time, there was an issue with them not having their minute clinics in low-income neighborhoods, particularly in Boston, I think Springfield, Worcester. So one, do we know if that's changed over time? And the second, do we have any data where folks are presenting at urgent care centers, but then being referred to emergency rooms? Because, I mean, that would obviously add to the cost of care. So it may be that folks presenting are unsure where to go. And is there some education that might be needed for the patient population?
Okay. On the first question of retail clinics, since there hasn't been really much movement in the market since 2018, you know, the situation sort of as described earlier would still be the same one today, in terms of location by income of the community. And your question about whether patients, I believe your question is whether you showed up to an urgent care center, but then you're sort of told to go to an ED. We're not I don't have any information on the frequency that happens. I think it's, you know, we know that is certainly some share of visits that is the case, but I don't have information on how often that happens. But I would say it's, you know, we know that it sort of highlights the difficulty in looking at, you know, which are facility fees for urgent cares and which are hospitals, because we know that sort of in that pool of facility fees that are marked as EDs, some are, you know, some minority is, you know, true patients are going to multiple settings of care in a day, and some are simply being billed as emergency departments.
Patty?
Yeah, Sarah, this is eye-opening information, I have to say. So I work with employer purchasers of healthcare, and the message they've been giving their employees for many years now is, if you're able to avoid the emergency room and take advantage of these freestanding services, please do so. It will save a tremendous amount of money. And what I'm seeing here today is, bottom line, that might not be the case. It sort of makes me think of the new legislation that was passed about no surprise billing. And I mean, honestly, if this happened to me and I was charged for an ED visit when I was going to one of these freestanding clinics, I would be surprised as anyone. And I guess I shouldn't be, given my experiences. So I think what this points to is that we need to recommend full disclosure, so that people are going in with their eyes wide open and understand what they may be exposed to in terms of cost. It's really alarming.
Thank you. Just to chime in quickly on this, there is a real policy opportunity here for that standardization and transparency. Included within Governor Baker's healthcare reform legislation that he filed earlier this year is a provisions that would create standard licensure of all urgent care centers as clinics. And this would have tremendous benefits, both from having a standard licensure and tracking mechanism, so we know exactly where all of these urgent care centers are. It would prevent the ability for these clinics to charge the facility fees. And so this is, I think, a really important policy opportunity to create some standardization that would really address some of the challenges we're facing here. I think, you know, At the same time, the spending at an ED is quite a bit larger than at an urgent care center. And so if we can create that standardization so that patients aren't surprised about some of these billing practices, I think it would only strengthen the opportunity for savings in these alternative care sites.
David, one of the follow-ups on this, I think, may very well be to see if the commission wants to weigh in formally in some type of letter or communication with the legislature and the administration about some of this. And I don't want to prejudge it, but I think we should consider that if we feel that way. Don?
Thanks, David, and wonderful, Sarah. As I often feel with staff presentations like this, I hope this gets published in peer review literature. It's too good not to be. Sarah, did you get a chance to review literature on quality of care? I know you look low acuity conditions, but do we know much about the relative quality of these? I may have missed that.
I think overall, our work did not focus on quality of care, but particularly for the management of low acuity conditions, which is what these sites are sort of optimized for. I think it's while I can't speak to quality of care, I think looking at when you're in a world of looking at sort of treatments of coughs or, sort of administering a strep test, I think sort of for that set, it's a more sort of straightforward, in and out type of service.
I should know the literature on this, but there still would be things like overuse of antibiotics or diagnostic testing. Sure. Or follow-up quality, things like that might be studyable. So
sure. Well, it's a good point, and we'll look further into that for the data points.
Tim, I'd seen your hand up. Do you want to jump in?
I put it back down. I mean, one thing I was just thinking about, and it's not directly related to the questions that are occurring now, so I didn't want to distract, but also, are we seeing a growth in for-profit ownership of the retail clinics or urgent care centers? Is that a pattern that we're seeing within these urgent care clinics and retail clinics?
My understanding is that the large chains are mostly for-profit models.
David Seltz, what if the commission wanted to take a formal view, what would, in terms of a recommendation, what would we do? Maybe while you think about that, Barbara just raised her hand, so I'm going to let you stall for a minute, and I'm going to call in Barbara.
Thank you, David. Sarah, is there any way of knowing patients that are seen at urgent care centers then being seen in hospital-based services within so many hours or days? For example, 48 to 72 hours later. Is there a method to investigate that?
It's certainly something that we can consider looking at for additional investigation for the data points. There are some sort of technical challenges in distinguishing multiple sites of care for the same patient within short periods of time, but we can certainly look more into it.
Yeah, thank you. It would be interesting to see, first of all, if that could be done, and secondly, whether there's anything useful gleaned from that in terms of quality of care. Mm-hmm. Thank you.
Okay, David, enough stalling.
So I think there are a couple of opportunities here. One, we are planning to publish a data points with this research, and as part of that publication, I think could certainly highlight the policy opportunity as described and the provisions as proposed by the governor. I would note that this is a topic that the legislature has also been very interested in over the years. Both the House and Senate have considered this, and as they're considering legislation this session, certainly we will continue to highlight this opportunity. But I think both in the written data points, and then of course we are also, as we shift to the next presentation today, preparing for the cost trends report this year, again, an opportunity for policy recommendations. So I think multiple opportunities, and certainly with this public presentation, also wanted to highlight the proposal in some of the legislation.
Okay. Thank you. Any other comments on this topic? If not, what I'll do is I will turn it over to David Seltz to introduce the cost trends report, the impact of COVID on ambulatory care.
Great, thank you. I think we will turn very quickly to this next presentation. This is a preview of findings from our upcoming cost trends report. As you may remember from in recent years, we have kind of shifted the time in the year when we are preparing the cost trends report. And so what used to be kind of at the end of the calendar year has now shifted to be more of a mid-year report due to reporting changes at CHIA and their annual report. So we have already started to preview some of these findings, but the next couple of meetings, we really are going to do a deep dive into this year's cost trends report, which will have to a great deal of focus on the impact of COVID-19. And so to begin the presentations on the findings of the report and to begin to think about policy recommendations, I will turn it over to Laura Nasuti from our Research and Cost Trends team to talk through today's presentation.
Great. Thank you, David. Good morning, commissioners. Excited to be here to talk to you about our ambulatory utilization work. Leiden Marcelat and Dr. Sasha Albert will be joining me in presenting these findings, but I also want to acknowledge our other researchers who directly supported this work, Justin Keel and Dhruv Mandalia. We know that over the past 2 years, the COVID-19 pandemic has disrupted healthcare delivery and access. Prior work from the HPC looking at emergency department visits and inpatient stays found large initial drops in March of 2020. These visits and stays approached 2019 levels by the end of 2021. So for our 2022 cost trends report and future reports, we will be broadening the scope to look at what changes in the healthcare system persist, including ambulatory care. And we'll be trying to ask some of these questions, such as, were there similar declines in use of ambulatory care as we saw with hospital inpatient stays and ED visits? What are the longer term implications of any deferred or missed care? And how do we address these? And there are some more questions on this slide, but I think I'll move to the next slide because we're going to get into those in a little bit with today's presentation. So our next slide is actually a preview of our 2022 annual cost trends report outline. As Director Seltz mentioned, we will be highlighting the key findings from our second chapter today, that is changes in ambulatory care during the COVID-19 pandemic. At our next board meeting in early June, we will be sharing key findings from our first chapter on Massachusetts spending performance, as well as key findings from our 4 chart packs. And then at the July 13th board meeting, we will be presenting our performance dashboard and policy recommendations for discussion. Next slide. Back to today's presentation, our sister agency, CHIA, released the 2022 healthcare spending data this March, the 2020 healthcare spending data this March. And we could see from that data that the reduction in Massachusetts commercial spending in 2020 was driven by a reduction in hospital outpatient spending. So that shows a decrease of 9.4%, and professional spending with a decrease of 7.6%. As we know, spending is a reflection of both price and utilization. Today, we are focusing on utilization specifically for care that takes place primarily in offices and hospital outpatient departments, but we will be discussing prices at our next board meeting with the price chart pack. So next slide. So what do we already know about changes in ambulatory care during the pandemic? We've been looking at some national data for a while. The national data shows that there was an overall decrease in care the spring of 2020, and that care remained below 2019 levels. One paper puts it at about 5 or 6% through 2020. both high value and low value services. So for high value, think of preventive visits and cancer screenings, and low value services. Some of our low value care measures are vitamin G tests or other unnecessary imaging, declined similarly at first, but both started to return to prior levels. However, high value services started to return to prior levels a little bit faster than low value services, although there was definitely variation by service. In Massachusetts specifically, we found that emergency department visits still remained below pre-pandemic levels in 2021. We saw the largest declines in potentially avoidable emergency department visits and visits for children. At the last board meeting, we showed that there was some evidence that the decline in ED visits may have been due to some small shifts of care to other settings such as urgent care and telehealth. However, some of the missing or absent care may have been due to changes in care seeking behavior, such as people not seeking any medical care or reduced transmission of other infectious diseases. And something that we're going to talk about more later in this presentation, last spring, we did a deep dive using a novel data set, the COVID-19 research database, to understand how residents of the Commonwealth were accessing ambulatory behavioral health care during the pandemic. And in that data set, we found that telehealth use for behavioral health lasted through 2020. But at the same time, almost a quarter of pediatric patients in this data set appeared to discontinue care. Following the impact of the COVID-19 pandemic on pediatric behavioral health access has been an important area of focus for us over the past year. Next slide. So for today, we will primarily be using data from CHIA's all-payer claims database to examine ambulatory utilization for commercially insured members from 2018 through 2020. Dr. Sasha Albert will be presenting our pediatric results. This section will examine use of preventive, also known as well visits, and problem-based visits, also known as sick visits, lead testing, and will examine pediatric use of mental health therapy during 2020. But first, Leiden Marcelot and I will present some of our key findings on adult ambulatory utilization, including overall use of the health system, preventive and problem-based visits, preventive screenings, and some of our low-value care measures. With that, I'm going to hand it off to Leiden.
Thank you, Laura. For this section, we will look at adults 18 to 64 who had continuous coverage in the year. Later, we will also quickly look at a cohort of members with known chronic conditions to see how routine care has changed in the post-COVID period. Next slide, thank you. Prior HPC research showed that commercially insured residents in lower income zip codes were more likely to go without care. From 2018 to 2020, this pattern attenuated a bit. Here we see the share of population without medical spending in the year by the average income of their residents. The blue bars are 2018 and the orange bars are 2020. The numbers at the bottom indicate the lowest income communities on the left and the highest income communities on the right. And the boxes below the bars indicate the percentage point change in that 3-year period. And we can see that though the previously identified pattern persists here with lower income communities more likely to go without care, that there was a slight decline in the share of non-utilizers for the lowest income communities and an increase in the share for the highest income communities. Next slide, please. Here we'll look at changes in preventive visits. Overall, these visits declined 23% from 2019 to 2020. Here we show these visits broken out by the lowest and highest income areas. And this time we're going to look at quintiles, which would show the lowest and the highest 20% of average income here. And we see that despite declines for both groups in 2020, those in higher income areas use telehealth for a greater proportion of their visits. Next slide, please. On the next slide, we do see the same for problem visits. Here the telehealth utilization was about 30% for both groups, but the share was greater in the higher income communities. And here we're looking at the problem-based visits. Next slide, thank you. Problem-based visits are coded by the complexity of the visit and whether the patient was new or established. Here we show the distribution of the visits by the procedure code for established patients only from 2019 to 2020. The height of the bar shows the volume for these visits. And we can see the same overall decline occurring in 2020 overall. But the bars are also stacked with the share of the least complex visits on the bottom and the most complex visits on the top. And we can see, and we can see that there was a shift towards the shorter, less complex visits in 2020. And this was more pronounced for the established patients. Next slide, please. Here we look at a cohort of patients who were flagged with a chronic condition in 2019, and we wanted to see how their care changed after the onset of the COVID epidemic. So here we're only looking at their utilization after March 15th and throughout the rest of the year. And we also look at, with the blue bars on the left, the lowest income quintile, and the bars on the right, the highest income quintiles, as we showed you previously. And we're going to look at 3 measures of their utilization. Now here we have a cardiometabolic cohort on the left that are folks who had cardiovascular disease, diabetes, or hypertension. And they may have had other chronic conditions as well. And we looked at a similar cohort in the 2018 cost trends report. And we also contrast that with an asthma only cohort, which were folks also flagged in 2019 that only had asthma as a chronic condition, so no other chronic conditions. The cardiometabolic cohort is about 165,000 folks, and the asthma cohort is a smaller cohort of about 10,000. And here we're going to see how the share of members that actually received either an adult preventive visit, a problem-based visit, or a problem-based visit that was conducted via telehealth. And we were concerned about how restricted access to ambulatory care during the pandemic may have led to disruptions in routine care. So we want to just follow the same folks from 2019 and see what happens in 2020. And so these are, a cohorts of with known chronic conditions in 2019. And the cardio, excuse me. And so what we can see here is that though for the cardiometabolic cohort, members receiving a problem-based visit, was about the same for the lowest income and highest income quintile. We see that also for the asthma group, that for members receiving an adult preventive visit and for problem-based visits conducted via telehealth, there was a greater share in the highest income quintiles. And now I'm going to turn it over to Laura.
Thank you, Leiden. So now we're going to look at some other high value care measures. We're going to look at specifically cancer screenings and hemoglobin A1C testing for patients with diabetes. Overall, we found a 22% decrease in the number of members receiving one of these preventive care services in 2020 compared to 2019. When we examine this data by quarter, starting in 2019, all the way on the left, we see that colon cancer screening, which includes both colonoscopy as well as lab tests to detect potential colon cancer, dropped by 77% in the second quarter of 2020. This is the dark blue line, Mammography screenings, the orange line, dropped a similar amount, while diabetes A1C testing dropped the least of these preventive services. By the last quarter of 2020, only mammography screenings were above 2019 rates, potentially hinting at a slight recovery. Next slide. Here we look at mammography screenings in more detail and by income quintile. The mammography rates for individuals who live in the lowest income communities are represented by the blue bars, and these rates and the rates for individuals who live in the highest income communities are represented by the orange bars. As you can see, throughout 2020, individuals living in the lowest income quintiles had fewer screenings per potentially eligible member. This was also true in 2019, not shown. When we compare 2019 and 2020, we find that this disparity in screening rates slightly worsens. It increased from 13% in 2019 to 15% in 2020. So that was our dive into some preventive care screenings and testing. But for our next slide, I'm going to pivot from those findings. We wanted to understand if some of our standard low value care measures also saw decreases. Unlike preventive care screenings, low value care would be something we hope to see less of, and is something that we have been monitoring for a couple of years. On this slide, we find that all the low value care measures we examined saw decreases in their utilization rates from 2019 to 2020, ranging from a 74% decrease from vitamin D testing to a 12% decrease for thyroid T3 test. Although vitamin D saw the largest decrease, I want to note that over the past several years, we have been seeing a decrease in vitamin D testing. It is the low value care measure that we have seen the most movement on. This may be changing due to both provider and payer policies, as well as access to care during the COVID-19 pandemic. We will be looking at these measures more in depth for our provider organization performance variation work that will be featured in that chart pack. Now I'm going to hand it over to Dr. Sasha Albert to discuss our pediatric findings.
Thank you so much, Laura. So turning now to findings on ambulatory care for children in Massachusetts. Next slide, please. We first looked at the share of Massachusetts children, so ages 0 to 17, who had no medical spending in 2018 and 2020. Overall, 2.5% of children had no medical spending in 2018, a share that nearly doubled to 4.4% in 2020. And as shown in the graph, both the baseline share of children with no medical spending in 2018 and changes in 2020 varied substantially by community income, with the lowest income communities on the left-hand side and the highest income communities on the right-hand side. And while the rate of children without medical spending each year is lower than for adults, it is concerning because when kids have no medical spending, it means that they did not receive the recommended preventive visits that children should have each year. And with that, we'll now turn to look at use of preventive visits, also called pediatric well visits, on the next slide. So here we measure rates of children receiving recommended visits rather than total visits, because children of different ages have different recommended numbers of pediatric preventive visits each year. And so we found that overall rates of recommended pediatric preventive visit use remained high in 2020 relative to many other services, declining by less than 3% from 2019. However, we do see that children in the lowest income communities, again on the left-hand side, consistently had the lowest rates of recommended preventive visit use from 2018 to 2020, as well as the largest decline from 2019 to 2020 of 4.8 percentage points. In a separate analysis not shown here, we also found that of all age groups, teenagers were most likely to lack recommended preventive visit use in 2020. The next slide shows the change in the share of children with recommended preventive visit use, as well as the share of pediatric preventive visits taking place via telehealth across regions of the Commonwealth. And here we look at preventive visit use and telehealth use only among children ages 5 and older, who are not necessarily getting vaccines or screenings at each well visit, meaning that their preventive visits don't necessarily need to be in person. So the map shows the change in the share of children with recommended preventive visit use from 2019 to 2020. So regions in darker shades of blue had larger drops in the share of children with recommended preventive visit use. The bars on the map and the percentages under the bars show the share of all pediatric well visits per region that took place via telehealth in 2020. So we see that Metro Boston had by far the highest rates of telehealth preventive visits, followed by the Pioneer Valley. So as we can see from this exhibit, there does not appear to be a pattern as far as maintenance of pediatric preventive visit use by region and use of telehealth in 2020. On the next slide, we move to looking at problem-based visits. Total problem-based visits for children declined by almost 30% from 2019 to 2020. This drop was driven by a decrease in the number of children having many visits during the year, as shown in the left-hand graph. Those two bars show the share of children with different volumes of problem-based visits per person in 2019 and 2020. We see that the share of children with no visits in the dark blue, or only 1 to 2 problem-based visits in the orange, increased in 2020 compared to 2019, while the share of kids with 3 or more visits decreased. The right-hand graph shows the total volume of problem-based visits from 2019 to 2020 by patient age, with 2020 broken out into in-person and telehealth visits. And we found that the youngest children, those under 2 years old, had the steepest drop in the number of problem-based visits in 2020. Looking at older kids, teenagers had the smallest decline in problem-based visit use, as well as the highest volume of visits via telehealth. Shifting now to look at pediatric lead screenings, we looked at screenings for lead exposure in 2019 and 2020 for children ages 1 to 3. Lead screenings in Massachusetts are required for all children ages 3 and younger. And similar to data reported by DPH, which found a 10 percentage point decrease in statewide lead screening rates from 2019 to 2020, we also found a decrease in the rate of pediatric lead screenings among commercially insured children ages 1 to 3. Broken down by income, we found that while children in higher income communities had larger drops in lead screening rates from 2019 to 2020, they still maintained higher rates of lead screening in 2020 than children in lower income areas. Next slide, please. So as with adult care, we know that some changes in pediatric utilization in 2020 were likely related to care avoidance or changes in infectious disease exposure. So to take another look at utilization trends, we examined a subset of kids who would be expected to still have healthcare utilization and especially problem-based visits, independent of COVID-related shutdowns. So for this analysis, we looked at utilization among only commercially insured kids with full years of enrollment in both 2019 and 2020, and who had diagnoses of chronic conditions, namely cancer, cardiovascular disease, diabetes, or epilepsy as of 2019, which retained about 8,500 children for analysis. And for these kids, we looked at their utilization after March 15th in 2020, so after COVID shutdowns were in effect. And looking just at this cohort of about 8,500 kids, we compared children living in the lowest income communities in the blue and the highest income communities in the orange. And we found that kids with chronic conditions living in high income communities were more likely to have preventive visits on the left, problem-based visits in the middle, and to use telehealth for their problem-based visits as shown on the right. Turning now to findings on pediatric mental health. The next slide shows quarterly therapy visit volume and share of visits in person and via telehealth for 2019 and 2020. And here I want to note that this slide includes only kids ages 16 to 17 due to very low visit volume among the youngest kids. We found that pediatric therapy visit volume increased by 23.5% in 2020. And that visit volume was not only maintained, but actually increased starting in spring of 2020 compared to 2019. And again, this is for kids ages 6 to 17 only. And this is in stark contrast to all other types of care that we've examined so far for both adults and children, which declined in 2020. So the next few slides show our findings for mental health services for a slightly different subset of kids. So for these slides, we looked at children of all ages, 0 to 17, who had behavioral health diagnoses and also had therapy visits in January and February of each year. And then we followed those same children from March 15th to December 31st of the same year to understand what share of kids discontinued therapy, and then of those who continued, how they accessed their care. This analysis is modeled after results that we presented in February 2021 using a special COVID data set, which Laura mentioned a few minutes ago. So this format of results may look familiar. So here we see that in 2018 and 2019, about 8% of kids with therapy visits in January and February discontinued care by the end of the year, as shown in the yellow. By comparison, in 2020, 15.6% of kids discontinued care by the end of the year. And of those who continued, most received services only via telehealth, as shown in the dark blue. The gray shows the share of kids with mixed model care, that is some telehealth and some in person. And the light blue indicates children with services only in person. And here I want to note that while we found a relatively high share of discontinuers in 2020, we also found on the previous slide higher therapy visit volume. And these results together indicate that the rise in visit volume seems to be driven by higher intensity of use. That is, more visits per person in 2020 rather than a larger number of kids receiving therapy services. On the next slide, we explored the same trends in therapy continuation and discontinuation as broken down among children of different ages and between boys and girls. While children in all age groups and both boys and girls were more likely to discontinue therapy in 2020, again as shown in the yellow, younger patients and boys were most likely to discontinue care. However, apart from the very youngest kids, ages 5 and under, all groups had approximately similar rates of telehealth use among those who continued care. And then lastly, on the next slide, we examined therapy continuation and discontinuation among children living in low and high income communities. Children in low income communities on the left were more likely to discontinue therapy in 2020 than children in high income communities. And children in low income communities also had slightly lower rates of telehealth use. I'll now pass back to Laura to share conclusions from our findings.
Great, thank you, Sasha. We have a couple of concluding slides. We presented a lot of material today, so I'm just going to highlight a few of our findings right now. So while we found that overall ambulatory care decreased in 2020 compared to 2019, what we've shown today is that where and what care decreased varied. Adult office visits dropped 23% for preventive visits, but only 3.5% for problem-based visits, while children showed only a small decrease in preventive visits, and they had a much larger decrease in their problem-based visits. About a third of problem-based visits were delivered via telehealth. Sasha just wrapped up the section on mental health. We saw that mental health visits for children ages 6 to 17 actually increased in 2020 by 23%, and many of these were also delivered via telehealth. And all of our low value care measures that we examined decreased from 2019 to 2020. Next slide. When we looked at some high value care, such as cancer screenings and hemoglobin A1C testing for people with diabetes, we found that these high value screenings and testing dropped 22% in 2020. Disparities in mammography screening rates by community income levels increased slightly in 2020 from 2019. The percentage of children receiving pediatric well visits dropped by 2.8 percentage points in 2020, but this drop was not uniform. Children living in lower income areas saw a 4.8 percentage point drop in pediatric well visits. Next slide. And as both Sasha and Leiden mentioned, we created cohorts and followed both children and adults with chronic conditions. Again, these are individuals who likely should have been having multiple contacts with the healthcare system during 2020, and found that those who lived in higher income communities were more likely to receive routine care and use telehealth than those with these chronic disease conditions living in lower income communities. The rate of lead screening in children dropped similarly across all community income groups. And finally, we found that 16% of children who received mental health therapy in 2020 discontinued care after March 15th. In prior years, it was around 8% of children who had discontinued this care. Children who lived in lower income communities, were younger or male, had higher rates of discontinuation. Thank you for your time today. As we receive more recent claims data, we will be looking to see where care continues to come back, as well as understand the impact of missed care in 2020. And we welcome any questions. We have all our analysts on the call.
Thank you. That was a tremendous amount of stuff. We just wonderful. We have just a couple of minutes. I guess I'll try and just offer one comment first, which is, it seems like we as a Commonwealth did an extremely good job where we could in making up with telehealth for in-person visits. So particularly on the behavioral health care, but also on some of the other services, that looks like a big success. We did not do an incredibly good job, nor did the rest of the country do an incredibly good job making up for in-person services that were not provided in the height of the pandemic. So colonoscopies and mammographies and other kinds of services that were deferred didn't get rescheduled later, so they're down total during the year. And so I think that's probably something that we'll have to pay attention to, is how do we, what is the consequence of missing those? At the same time, it also indicates that our telehealth policy is going to be really important, because I was stunned by how important was telehealth now in terms of behavioral health care. It looks like just a complete sea change in how behavioral health care is taking place for, you were showing for kids, I suspect for adults as well. So those are just kind of a couple of things that occur to me in looking at them all. Let me see if any of my colleagues want to offer thoughts, or Flora, you wanted to jump back in on anything?
I think that's all right. For the actual cost trends report, we will be adding to some of the findings, including adult mental health and utilization of telehealth there. We prioritized the pediatric findings for this particular presentation, but for the final report, as usual, we highlight some findings, but we don't necessarily get to all of them for the presentation. Yeah.
There's an enormous number of them too.
Do we have any sense of what happened in 2021? Have things really come all the way back, or have they stayed similar to 2020? Do we know anything about 2021?
So for ambulatory care, so that office-based care or hospital outpatient department-based care, we don't have insight into what is happening there. We did present on emergency department utilization, and we have hospital inpatient data saying that we're getting closer to 2019 levels. But for some of this work, we really need the claims data through 2021 to be able to answer those questions.
Thanks.
Okay, so I think at this point, what I'm going to do is I'm going to turn it over to Barbara, who's going to do the transition. I'm going to listen, but I'm going to have to turn off my monitor to go to somewhere. So Barbara, let me turn it over to you. Oh, you're on mute, Barbara.
Thank you, David. I appreciate the intro. And we are about to, let me just get to my right spot here. We're about to be joined by a guest today, someone who has done a tremendous amount of work and the work that we are extremely interested in, and that is Dr. Bradley Post. Dr. Post is a co-author of a new academic research paper, Hospital Physician Integration and Risk Coding Intensity, which shows how upcoding practices are becoming more severe and more widespread. Dr. Post is an assistant professor in the Department of Health Sciences at Northeastern University, the Bouvet College of Health Sciences. His research in health policy and healthcare delivery systems explores hospital physician vertical integration, hospital employment of physicians, and Medicare payment policy. His work also encompasses the relationships between Medicare payment policy, provider consolidation, and healthcare spending. And in his 2018 Vertical Integration of Hospitals and Physicians, Economic Theory and Empirical Evidence, he was awarded the Medical Care Research and Reviews Article of the Year. Dr. Post has recently co-authored a paper titled Hospital Physician Integration and Risk Coding Intensity, which caught the attention of us, the Health Policy Commission, due to its finding that upcoding practices are becoming more severe and widespread, consistent with and expanding on prior HPC research. We're very excited to have Dr. Post with us today to present his new research. And Dr. Post, let me give you the podium.
Thank you very much, Barbara, for that warm introduction. I appreciate it. And just want to confirm, everyone can hear me? All right, that's good to know because I was having some internet connectivity issues on today of all days, and naturally, one has to make sure that all the logistics are in place first. So I just wanted to say thank you for having me here. I'm really excited to be here. So thanks to Executive Director Seltz and to Chair Cutler, and also to Dr. David Auerbach, who noticed this paper and wanted to reach out. So for today, I'm going to give you a brief personal introduction and then sort of orient you to the topic. You can see right from the very start, the very first set of words on the screen, it's full of jargon. And so I'm going to do everything I can to break that down and make sure that it's both more interesting and more enlightening. But feel free to pause me and interrupt at any time if you like. If you want to talk in more detail or just have a question, that's totally fine. And I've also got some space reserved at the end to hear from you all. So without further ado, let me proceed. Hopefully I can control the screen. Thank you, Hannah. It looks like it's working well. So as Barbara mentioned, I am at Northeastern University. I'm an assistant professor there. And just to orient you to kind of the overall objective of my research agenda, I'm really interested in how system level integration of providers affects quality and affordability. And to that end, Barbara mentioned this paper. I wrote a review a few years ago in which I did a deep dive into one specific instance of that, which is hospital physician integration. Now, as many of you probably know, historically in the United States, there were physician practices who did their own thing, and then there were hospitals, and when physicians needed to do inpatient-based care, they went over to the hospital and did their work there, sort of the physician's workshop model, it's sometimes called. It appears that those days are sort of fading. It really looks like an era of much more consolidated delivery systems is upon us and is growing. So we see a lot more now of hospitals buying out physician practices or directly employing physicians, sometimes right when they come out of their residencies or right out of their training. And so it's a big shift in the way that we organize healthcare delivery in the United States, with lots of implications for spending and quality and lots of other things too. So in this paper, I had pointed out a few of the gaps in the evidence base, and since then I have been working to try to fill some of them. And so I'm going to talk to you about a little bit of that today. So recently, I published a paper on hospital cardiologist integration. I think understanding the integration of specialists is becoming increasingly important. Turns out that early career cardiologists seem to have a pretty big role in this transformational shift. I also published this paper, which is a little screenshot on the right here. I'm looking at the effect of Medicare payment policy on hospital physician integration. I was so glad to listen to Sarah's presentation because she had the difficult task of explaining facility fees and how they're billed on top of professional fees, and that way I don't have to. Excuse me, I don't have to. And so, for a long time, physician practice, if it were owned by physicians, could bill a certain amount, but if it were bought out by a hospital system, it could be converted to an outpatient department, and suddenly reimbursement goes up a lot, quite a lot actually. And so there's been some concern that, well, maybe this is driving some of the consolidation, and there is some evidence for that. Also, just a brief sidebar to Sarah, who's working on some of the urgent care issues. You may be interested in some research that's coming out from Giacomo May. He's a brilliant guy who's over at ARC, and he finds that there's some substitution when urgent care centers enter the market, but mostly not away from EDs, mostly away from physician practices. So I can send you contact information on that if you like. Might be interesting to you. So I wrote this paper recently with these co-authors who were part of my dissertation committee at the University of Michigan. And that paper actually just found out last week that Health Services Research awarded it the Article of the Year. And I think that mostly speaks to the timeliness of this as a policy issue and the importance of paying attention to how to think about what our healthcare delivery system looks like going forward. So today I'm mostly going to be talking about the relationship between integration, which is one policy relevant issue, and then risk coding intensity or upcoding, which is another policy relevant issue. But before I go too whole hog on that, let me give you sort of fly back up to a 10,000 foot view. So to sort of couch hospital physician integration in a context that makes sense. So in the American economy, we've seen plenty of corporate consolidation, mergers, acquisitions, buyouts, more and more concentrated markets in certain sectors at least. And healthcare is no exception. We've seen plenty of consolidation in healthcare, whether that's insurance companies, whether that's hospitals merging with other hospitals. And I'm focusing here on one specific subset of that, and that's hospital physician integration, sometimes called vertical integration. And so this is, as I mentioned, where there's one dominant health system who that will have ownership or direct employment relationships with the many physicians in the community. So just a couple of notes here. This is moved away from being strictly an academic concern, and it's gotten lots more attention, splashy headlines with the CVS Aetna merger, $69 billion record-setting merger a couple of years ago. And then also increasingly the hospital relationship with physician practices is becoming more and more commonly understood. So in broad terms, why would hospitals and physicians integrate in the first place? And what is the point of this? There are two parties, in this system, and physicians. We don't know a lot actually. There's still there's some gaps in the literature on really understanding the causes. I have a doctoral student that I'm working with on this issue, and so from the physician side, what we often hear is it's harder and harder to practice medicine. It's more complicated than it used to be. There's more electronic health records are a really big investment. They're expensive. You need IT support. There's some talk that the growing federal regulations around reporting requirements and participating in certain alternative payment models just makes it a little bit harder to do things as a solo practitioner or in a physician-owned setting. And on the hospital side, I think that it's fair to say market share seems to play a role here. Hospitals provide lots and lots of important services, but they also seek to maximize revenue and minimize costs. So market share is one feature of this. It seems to confer some leverage with payers. If you're a hospital and you own most of the cardiologists in an area, that seems to confer benefits to you when you come to the table with Blue Cross Blue Shield or United Health or whatever it is, and you're trying to negotiate rates. Seems that is one effective strategy. So that might be one reason. And then the reason that Sarah alluded to earlier is to take advantage of Medicare payment policy or many commercial insurers too pay more for the same services delivered to the same patients in the same setting. Medicare has since made some policy changes around that, but commercial payers, as far as we know, are still doing this pretty regularly. So those are that's some of the background for why we might see some of this integration. A little bit about what we know so far. Integration has been increasing rapidly. That is well documented at this point. Saya Nikpe had a paper in Health Affairs about that. Some other reports from Avalier Health and the Physicians Advocacy Institute. Things are going up very quickly on this front. I think for the first time last year, first time ever in American history, there are more physicians that are working for larger conglomerates than in physician-owned practices. So this is sort of new territory for us as a healthcare system. We also know that integration is associated with higher prices and spending. So as I mentioned on the last slide, it seems that there's some bargaining advantages with respect to commercial payers to vertically integrate in this way. One of the papers I really like in this area is Capps, Drainov, and Odie, and they found that for primary care, I think it was, that after vertical integration with a hospital, physician prices increased by almost 14%. I mean, think about that for a second. If all healthcare prices increase 14% and your premiums went up 14%, this is completely unsustainable. So the higher prices are an issue. Spending also seems to increase, even setting aside prices. There seems to be some evidence that there's greater utilization. So those are some of the effects that we see. And then the effects on quality have somewhat disappointingly been more mixed. You might hope that bringing inpatient and outpatient settings together could help to make more coordinated care and coordinated care and could some overall there's not enormously compelling evidence for that at this time. And so we would have to, I'm sorry, can you all hear me still?
Yes, you kind of turn into Darth Vader a little bit there.
I've been known to do that.
It sounds a little clearer now.
Okay. All right. Please jump
okay.
in anytime I go full Vader on you.
Okay.
My apologies for that. So the effects on quality have been a little bit more mixed. We've got underway. If you can all still hear me. So research going on at Northeastern. I work with Gary Young and his Center for Health Policy at Northeastern. We have a lot of active projects on this topic. So one of the papers that just came out in Health Affairs was on inappropriate imaging. It appears that when it comes to primary care physicians, if you're getting care from an integrated primary care physician, there was an increase in the probability that you got inappropriate imaging, things like MRIs for non-specific low back pain, that kind of thing. And in emerging research that we're working on, focusing on cardiology, we're finding that patients with certain cardiovascular conditions actually appear more likely to get more intense care. So more likely to get catheterization or an angioplasty. And so these are effects that are not just like imaging, but also appear to matter for treatment mix and treatment intensity that could have pretty major implications for downstream quality of care. We also have research under.
Brady, could I interrupt you for just a second? Could you go to on your Zoom controls near where it says mute, there's a little arrow, and do a test for your microphone? I think that might fix the distortion that some people are hearing.
Okay. Maybe I can just hang on.
Can you hear me now?
Oh, that's much better.
That's better.
Excellent. Yes. Thank you so much.
All right. Well, we're going to just go old school. So let me turn on a speaker, make sure I can hear you all. Okay. Sorry about the technical issues, everybody. So as I was saying, some work going on at Northeastern. Patients with cardiovascular conditions seem to get more intense care, and that's not just an imaging thing, but also it seems to matter for treatment mix. And we're also looking at MIPS performance of hospital integrated physicians versus independent physicians. MIPS is the merit-based incentive payment system operated by CMS. So lots of ongoing work here. But one thing that we don't really know very well up until this came out last month was, what's this relationship between hospital physician integration and how intensely physicians code their patients' clinical severity? So thinking about things like number of diagnoses or the intensity of diagnoses. So this came out in Health Economics with my co-authors and mentors, Edward Norton, Brent Hollenbeck, and Andy Ryan, great scholars, great mentors, and I think some policy relevant conclusions here. Essentially, the paper is looking at this. We've got two trends. We've got this big increase in hospital employed physicians, and I cut off the y-axis for sizing, but the important thing about this is that it goes up and to the right. And then also an increase in risk scores. So this is actually from the Health Policy Commission's their own work. I'm a big fan of it. And so we see this notable increase in patient risk scores, or how sick patients appear to be on paper. So a little bit of motivation here. I'm getting a.
Brady, could you just tell us what that second slide, what all those colors were?
Could someone just speak up for a second, because I changed my speaker?
Yeah, can you go back to the previous slide?
Sorry, I can't hear that.
Okay.
Oh,
Perfect. That's what we wanted.
now you're back. Now you're back.
Okay.
Okay.
What are all these on the right-hand side? What are all these lines?
Yeah, that's a good question. And I had to, again, crop it for space. These are health plans. These are the risk scores for beneficiaries in different commercial health plans in the state of Massachusetts. So a risk score, as many of you may know, I'll explain in a little bit more detail, is a sort of a composite measure for all of the different features, whether demographic or disease related, that predict spending. So they're a measure of clinical complexity, and providers have a lot of influence over how many diagnosis codes appear in a patient's medical record and appear in claims, and it affects reimbursement, as I'll explain in a little bit more detail. But some work by Dr. Auerbach and his team has shown that these increased very, very noticeably. These risk scores increased quite dramatically over the course of just a short few years, and it's not clear that these are actually closely connected to the underlying health of the patient population. Am I making sense? Does that answer make sense? Okay.
Thank you.
Of course. So a little bit of motivation here. Why might, I'm sorry. Why would a hospital want its doctors to code patients more severely? If I were giving this as a lecture in my classes, I would probably pause here and wait for a student to break an awkward silence. But I'm just going to jump into some thoughts for you here. So risk scores are relevant in reimbursement everywhere in healthcare, and especially for hospital systems. So there are at least 3 ways in which integrated physicians, and probably more, at least 3 ways in which integrated physicians could help a hospital system gain more revenue through higher coded severity or higher risk scores. I'm going to be using those terms pretty interchangeably: coded severity, risk scores, patient acuity, all those sorts of documentation of patient clinical condition. So first of all, if you're a hospital and you own some practices out in the community, it might be helpful to know at all of those visits that they may have with their outpatient providers to do as thorough a job as possible to collect all of the diagnoses that they may have, so that when they have inpatient events and they need to come into the hospital and get inpatient services coded through the diagnostic related grouping system, it might be helpful to identify what those diagnoses were out in the community and then apply them to DRG settings. And that's because there's large financial incentives to do so. So just as an example, from 2017, Medicare reimbursed a coronary bypass that was coded without a major comorbidity or complication at $23,000. But if it was coded with a major comorbidity and complication, that reimbursement rose to $35,000. And so there's definite financial incentives to be thorough about your documentation. Secondly, hospital performance in pay-for-performance and alternative payment models has been increasing, and virtually all of these programs, the hospital value-based purchasing arrangement, the accountable care organization system, all of these are risk-adjusted, and for good reason. We want to have incentives for providers to treat the sickest patients out there. We don't want them to be cream skimming and leaving patients behind. But it definitely does push the incentive in the direction of adding as many diagnoses as possible to a patient's medical record. And then finally, there's been an increase in hospitals that will actually launch their own insurance product. So hospitals that will open up Medicare Advantage plans, and in Medicare Advantage settings, higher risk patients generate more plan revenue very directly. The percentage of increase of risk for a Medicare Advantage plan directly maps onto the percentage increase for what you're reimbursed on a per patient basis. So strong incentives there as well. Now, all the motivation, all that kind of stuff doesn't really matter if there's no opportunity to affect coding. So it's important to determine, is it realistic to think that providers have any influence on this? And I'm here to tell you, and I'm sure that many others on this call will say, yes, it does appear that that is possible. So a few anecdotes here. There's a whole cottage industry, actually, that's been built up around this. The American Association of Professional Coders, I think is the acronym there, has a lot of different coding certifications, including things like clinical documentation and case mix improvement, and all of that is built around adding diagnoses and increasing the apparent severity of patients. Office of Inspector General came out with a report not long ago finding that upcoded E&M visits, just E&M, this is not an expensive service in general, accounted for about $5 billion in annual excess spending. And then the nation's favorite health policy body found that coding effectively added 920,000 residents with cerebral palsy to the state of Massachusetts. I love this. I love this example. I've cited in this paper, and it speaks to this issue. Like, when you upcode patients, you can generate a lot more spending. In this case, adding almost 1 million patients with cerebral palsy, even if the underlying health of the population isn't all that different. So the authors of this HPC report were, I think we can say, skeptical that this large increase in coded severity actually mapped onto important changes in underlying health condition. And then some research also from Caruso and Layton that Medicare Advantage plans did successfully get their providers to code more intensely. I like this little quip as well. I talked to a physician colleague of mine who had documented that he had one of his patients had like a cut on their hand and it was bleeding, and so he made it mention that that there was bleeding, whatever, and got a call shortly thereafter from the billing department who said, "Now I see that you said in your charting that this patient was bleeding. Could we call it a hemorrhage?" And he said, "No." He said, "In this case, there's no way that we could justify calling this a hemorrhage." But it's important to just think about that as kind of the backdrop for practice settings. So the goal of this research was just kind of this first order question: is there evidence that coded severity increases with hospital physician integration? And if that's the case, then what are some possible mechanisms? So as I just explained, we know that integration is associated with increases in commercial prices, increases in utilization. This paper looks at, is it also associated with increases in risk scoring? I'm going to talk about my data and methods. I'm not going to bore you with all of the details. For those of you who really want to get into the nitty-gritty of the econometrics, I would love that. Feel free to follow up, and we'll set up an alternative time. But I'm going to try to just explain sort of the essential pieces of it. So to evaluate this question, you need to have patient risk scores over time, the status of physicians' integration with hospitals over time, a big sample for enough variation in those, and thinking about it kind of from a quasi-experimental point of view. So in the study window here, some physicians become integrated with hospitals. These are like a treatment group. They get the treatment, they get the pill. You can think about it that way. And then some physicians do not. They stay unintegrated the whole time. These are the control group, the placebo, if you will. So the data in this for this project is Medicare claims. I'm looking at 6 years of data from 2010 through 2015, focusing on Part B or carrier line items. About 1.8 billion line items when all is said and done. Took a while to process this. Anybody who has claims data experience can, I'm sure, can empathize, but it allows for a really robust sample. So in this study, we attributed each patient to one and only one primary care physician each year based on the plurality of care. This is to simplify the analysis to make it a little bit more concrete, that we can identify a treatment effect. And we use the Medicare ACO attribution methodology. It's become fairly standard at this point. And one of the important things that we do is we have a fully balanced panel, no case mix changes at all. Let me explain why this is important. You might imagine that after a physician joins a hospital system, that might signal to other patients like they're closely connected to a hospital. Maybe I want to go to them and then have an easier route to get to the hospital or hospital-based services like radiology and things like that. So you could easily imagine that after a physician becomes hospital integrated, that sicker patients sort of flock into the panel. That would be a huge confounder here. And so we want to avoid that. So this analysis is only looking at a balanced panel of, you can maybe think of them as like loyal patients. They stick with their doctor, one and only one primary care doctor, all the way through all 6 years of this study. So we rule out the case mix changes, which is good for causal inference. The sample winds up still being very large. We wind up with about 5 million physician patient year observations. That translates to about 76,000 unique doctors. It's about a third of the practicing primary care docs in the US. And then just shy of a million patients. Variables here, of course, the two that are important, the HCC score is what we use, the hierarchical condition category score. It's a very commonly used composite measure. It accounts for patient diagnoses, all of those things that a provider can add to a patient's record, and then also patient demographics and things like age and gender. So the HCC scores are directly applicable to lots of risk-adjusted models, including the Accountable Care Organization. All that stuff is, those benchmarks are adjusted for clinical severity. It's important to Medicare Advantage. So lots of policy relevant issues with HCC scores. So that's the model, or that's the variable that we use for measuring how clinically complex those patients appear to be. And then for hospital physician integration status, we use the place of service code and claims from the Harvard team, Hannah Neprash and Mike Chernew and Michael McWilliams. Hannah's actually now at Minnesota, wonderful researcher, and this has been a helpful paper for me. So, analysis. Do a lot of stuff in the paper. It's a long paper. I wouldn't ask you to read it, but I will just try to summarize the essential parts of it. So I'll focus on just the event study because that is the easiest thing to sort of intuit. Let me take a brief moment here to speak to the econometricians out there. So we're using an event study. I see a question here. Can we have the link to the paper again? Yes, definitely we'll send along. Thanks, Don. So in this event study setup, specifying it in this way to help to show that the parallel trends assumption has credibility. We can verify it in the pre-period. Of course, it's always an assumption in the post-period. Using a fixed effects for each physician-patient year. So all of the identification is only coming from the payers that have variation in integration status and HCC score over time. And then we estimate a fairly recognizable model, fully saturated model with leads and lags. So to the results. In this presentation, I've skipped the descriptive results because it's always a table that compares the treatment group and the control group. It's usually just a lot of numbers. It's very boring, and we'd rather get to the more exciting stuff. So let me show you, or let me tell you before I show the big reveal here, what we're expecting to see on the next slide. So in an event study graph, what you want to show is that in the pre-period, all of the there are estimates that are centered in each year that are close to zero. What this means is that the difference between the treatment and the control group in the pre-period is close to zero. That's good because you wouldn't want to have treatment effects that begin prior to treatment, it implies that there would be confounding. So you want to have close to zero or not statistically different from zero in the pre-period. And then there will be a dashed vertical line in the middle that separates the pre-integration period from the after integration period. And so on the right-hand side of the screen, if those dots continue to be centered on zero, it means that there was no effect. Both before and after, no effect. If, however, on the right-hand side of the screen, to the right of the dashed line, if those effects are different from zero, we can conclude that the treatment, and in this case, that's physician integration with a hospital system, had an effect on the outcome. Outcome here is a risk score. So here's what we find. So what we're seeing here is that on the left-hand side, there are no leading effects. There are no statistically significant effects in the pre-period. However, once we cross that threshold onto the right-hand side of the screen, to the right-hand side of this dashed diagram, we see a big jump. And this is in log scale. So the way that we can interpret this is that right here in the first pre-period, other things being equal, holding everything else constant, it looks like once your physician integrates, your risk score jumps up about 2.5%. And that number climbs as we go along. It ranges all the way from 2.5 to 3.7%, and stays significant all the way through this pre-period. So what that helps us to understand is it looks like even subtracting out general increases in coded severity over time, there's a special effect of being in an integrated system that causes an increase in coded severity. So thinking a little bit about that, actually, let me just pause for a second and back up to this slide. Does anybody have any questions? Let me just pause for a minute. I've been talking a lot. Feel free to jump in if you like, as I continue here. So thinking a little bit about how might this be happening? Well, one hypothesis would be maybe it's just that integrated doctors have a lot more physician contact. You take away all the billing and administrative nonsense and you just focus on clinical care. So maybe you get more visits with your patients. That gives you more opportunities to detect disease. And that could be a really good thing. So you could imagine maybe your primary care physician integrates with a hospital. It frees up some of their administrative time, less time spent on administrative hassle, and so they get to see you more often. And maybe you had undiagnosed depression that suddenly got diagnosed. That could be a really positive development, actually. So to see if that's likely to happen, not conclusive evidence, but plausible evidence, I think, well, we would expect then to see that integration should be associated with an increase in office visits. And so that's one of the things that my co-authors and I looked at in this study. So again, looking at that before and after graph, and here's what we found. Actually, if anything, it looks like following integration, physicians have less contact with their patients. So it's extremely unlikely that the effects on coded severity are driven by more patient-physician contact. That's just not, we don't find any evidence for that in this paper. A second mechanism could be more of a professionalization of coding, kind of a rationale. So you could imagine that once practices get integrated with hospital systems, that all of the billing and documentation, all of it sort of flows through the main office, goes through headquarters, it kind of comes out the same machine and spits it out on the other side. Physicians don't have to do it themselves, it's all centralized. That's one of the purported benefits of for physicians. And so if that's the case, then we would expect to see a little bit more standardization. That all kind of, all of this information runs through the same kind of black box and comes out on the other side. So we would expect, what statisticians would call reduced variance in HCC scores. So we looked at that too. Here's the graph on that. So again, on the right-hand side of the screen, it looks like a small effect. The dots are the point estimate, and then the bars are the 95% confidence interval, if you're familiar with that concept. And so we do find that the variance decreases a little bit. It's not wildly significant. You can see that those error bars get pretty close to the zero or null effect line, but it looks like the variance decreases by around 4%. So I wouldn't call this conclusive evidence that that's what's happening, but we do at least find evidence that's consistent with that kind of like back office professionalization, kind of a technology explanation is a pretty good way to think about these results. All right, let me summarize a few things, and I will and then I'll make some space for questions and discussion. So what we found in this paper, integration was associated through lots of different methods that we tried, pretty robust 2 to 4% increase in coded patient severity, independent of everything else about physicians and patients. It's not because they're seeing sicker patients, because we held case mix constant. So we know that's not the reason. It's not because of more physician-patient contact, because if anything, they had less. It's plausibly due to this back office professionalization or sharing of resources story that I just explained. And in order to try to translate this into more of a concrete number, since coded severity is sort of an independent construct and kind of weird to think about, it doesn't always map directly onto spending, else that's what I would have done here. So one sort of ballpark way to think about it is to get an increase in risk score of this amount, how much would you have to age in order to have that same increase in risk score? Because we know that age is correlated with risk scores. So it's the risk score equivalent of aging all of a physician's patients by 4 to 8 months. You can kind of colloquially speaking, overnight, once your doctor integrates, you appear to be a lot older on paper than you were. So about 4 to 8 months older. Some extensions of this work, some of you have probably already begun to intuit this. So some things that we're looking at Northeastern, thinking about these effects, not just in outpatient settings like this paper, but looking at inpatient settings as well. So thinking about DRGs, that kind of thing. The exposure in this paper was primary care physician, but it's entirely possible that if your specialist, your cardiologist, let's say, is the one who gets hospital integrated, the effects could be even larger because they diagnose conditions that are more severe. And then one important point here is that all of this data is just looking at Medicare fee-for-service. That's the lower bound here. Medicare fee-for-service doesn't have nearly as strong of incentives to do this upcoding as other programs do. So it's very likely that this is the lowest possible increase that we would see. We're anticipating much larger effects in Medicare Advantage analysis as well as commercial settings. So some clear extensions to better understand what's going on from different parts of the healthcare system. So a few conclusions. It looks like integration, in addition to having effects on commercial prices and spending, will probably also increase, in this case, Medicare spending through higher patient risk scores. Hospital systems can improve how they appear to do in these pay-for-performance models by helping their physicians to more comprehensively code their patients. And so whether this is good or bad, I think that Dr. Auerbach will probably chime in here. I think he would probably fall pretty hard on the side of it's not great. I would say just in fairness, there are really kind of two ways to think about it. On one hand, maybe this is just patients getting the diagnoses that they should have had all along, and they just got missed for whatever reason. And now they're in systems that have different technology, different processes, maybe some fancy software, consultants, all that kind of thing. And perhaps that could have positive effects in the long run. But if that were true, I think we would expect to see noticeable quality increases. And as I described earlier, it's been more mixed on that front. I think still worth exploring, but hasn't been overwhelming so far. And so if that's the case, then it may just be a needless increase in apparent sickness without actual sickness, just to gain the payment system. So I'm going to leave you with those thoughts and open this up for questions.
Wow.
I know that was a lot. Sorry.
Oh, well, no, Dr. Post, that is incredible, and exactly the data that we've been hoping to have come our way so that we can begin to take on this issue with greater detail and more research behind it. So thank you very much. This is incredibly impressive work. And I think we'd all love and be curious to know what your next steps are in this program of research. So
we'll have to do this again sometime. As you saw, I've got a lot of active stuff, and I would love to share what we're doing over at Northeastern.
I think you're going to be in high demand. I see several questions. Patty, followed by Stuart.
Yeah, thank you so much, Dr. Post. The part that jumped out at me was the hemorrhage. Can we code this as a hemorrhage? So do the coding consultants, that's my word for them, do they get a percentage kickback at all if they're changing the profile of a physician's patient base?
That is a very interesting question. I don't know of any peer-reviewed work that's done that. I know that that there are entire like tech startups dedicated to this. You can kind of do a plug-in with EHR systems, and that's their whole value proposition. Is like, look, you plug and chug with us, buy our software, and boom, revenue goes up this amount. I don't know about the specifically about the kickbacks, but definitely the incentives are there to try to for those consultants to perform.
Yeah. Okay, that's what I was afraid of, but thank you.
Can I just say that, I mean, Don Berwick has documented some of this in Medicare Advantage. There are actually, sometimes so-called pay for performance programs where there will actually be direct financial incentives for physicians to say, coding diagnoses up to a certain percentage of capture of previous year. They'll have sometimes targets where there are actually direct financial windfalls from that.
Thank you, David, for that. And Don, thank you as always for your good work. Stuart.
Yes, thank you, Brady. That was wonderful. So let me take you into our world and focus on your last slide and your last comments on your last slide. So when we go to the hospitals, particularly in our PIP system, the Performance Improvement Plan activities, and we see year in and year out, substantial increases in the risk scores such that increased spending disappears when you adjust for these risk scores, we become increasingly skeptical that these patients could continue to become sicker. The comment we receive back from the hospitals is, well, yeah, they're going up, and it's not that they're sicker, but before we weren't coding well, and now we're coding better. And so now we're better reflecting what these patients' true code should be. Well, that may be, but it ought to happen once or twice, but not for each year increasing. So when you look at this, do you see these numbers continuing each year to increase, or is it a one-shot deal? And at the end of the day, can you help us figure out really what's going on? I mean, the idea of just focusing on quality, I don't think is enough. We need to be very specific that this just isn't telling us what it's supposed to tell us.
I mean, you've really put your finger on the issue. It's that it's really difficult to, like, how do you think about the role of provider reported acuity in all of these payment models and quality programs? I think that it's, I don't think that there's an easy answer. It's definitely something that is an area that I'm thinking about and I'm trying to understand better. I find in this data, it's actually there's a slight climb over time, but not. It didn't look like the exponential, almost exponential growth that the Health Policy Commission has found. That might be related to the fact that I'm looking at Medicare fee-for-service data, and the incentives just aren't quite as strong as they may be in certain commercial or Medicare Advantage settings. So what I saw, at least in this paper, my co-authors and I saw was more of like a jump, kind of like a level jump rather than an accelerating increase. But there was some evidence that it did climb over time a little bit.
So the second or third, the question is, suppose it jumps by 2% after they come, what happens in the second year? Does it go back to zero, no growth? Or, I mean, even if it grows by, the question is, it's not that it has to grow faster, but if it grows each year, it's compounding.
Right. Mostly saw that it was like a more of a one-time jump, closer to a one-time jump than it was to like a huge increase. To your point earlier, like, you might see a couple of adjustments as providers get better with these systems or what have you. So there was a relatively small increase in years, maybe 2 through 4. It seemed to climb a little bit, but it was, I would say, still a little bit more. I'd like to get more recent data also on it. So I'm looking at 2010 to 2015. I would love to see what the acceleration looks like in a later period.
Thank you.
Thank you.
Yeah, building on Stuart's question, Brady, first, fabulous work. I thank you. And I look forward to trying to understand your paper, digging into it. Technically, it sounds wonderful. So just to Stuart's point, you did take a multi-year view of the post-merger, post-acquisition period.
Yes.
Is that in your paper? Is that to come?
Yes, yep, did look at on a year-by-year basis. So looking at it, looking at how those effects evolved over time. And it looked like, as I was mentioning, it looked like there was the first year had the smallest increase relative to the base period, and then it climbed up a little bit over the next 2 to 3 years. But then year 4 was kind of dropped back down a little bit. So it wasn't totally clear. And in event study models like this, statistically, the further out you get in the post period, the wider your confidence intervals become, and so the less confident you can be about the direction. So that's definitely something that's going to require closer monitoring and more follow-up. Thanks for your question.
I feel as though we could talk with you for the rest of the afternoon, and I'm sure we would all like to. Or is there one, David Auerbach? You get the final question or comment.
Sure. I just want to add that thank you. That was a great presentation, and that we can look forward to more to come. Our team is working on some additional data behind this, specifically in the commercial contracts, risk contracts, where this is an issue, and we will be also talking about some recommendations for how to mitigate some of this, how to mitigate some of the higher spending, without losing the benefits of incentivizing providers to take on sicker patients. And so that's probably in a few months we'll have more to say about that.
I'll be curious to hear about it.
That is great. Dr. Post, again, thank you so much for joining us. Your work is extremely exciting, and future focus will be extremely impactful. So we thank you,
Barbara.
all.
Thanks everyone for having me.
Thank you for joining us. Okay, folks, with that, I get the privilege of concluding a committee that I do not chair, but that's fine. David has had to step away. So at this point, we will be adjourning the MOAT meeting and immediately transferring to the CDT committee meeting. So if you need to step away for a couple of moments, we completely understand. So I'm going to call the CDT meeting to order and welcome you all. Hope you're comfortable or can get comfortable. And we'll begin the meeting by reviewing the minutes and looking for a vote to approve the minutes.
Actually, Chair Blakeney, I have the sad news to report that we do not have a quorum to approve the minutes because unfortunately Commissioner Berwick missed the last meeting, and so we would ask him to abstain. So if Undersecretary Peters does come, I will let you know and we can dispense with the minutes at that time.
Okay. Well, one thing that we can put aside for a few moments. Let us then move directly into our presentations for the day. Today looks a little different from what we normally do. but it represents a great deal of work on behalf of the staff. And so, Kelly, I'm going to turn it over to you.
Thank you so much, Commissioner Blakeney, and good morning, Commissioners. Looks like it's still morning. Today, my colleague Vivian Hemme and I are here to share some of our work and solicit your perspectives on strategies to amplify our efforts in care delivery transformation. Next slide, please. We bring this topic to you because it ties so directly to the HPC's mission and its vision of a transparent and innovative healthcare system that produces better health and better care at a lower price for all the people in the Commonwealth. The Healthcare Transformation and Innovation team supports this mission primarily via two vehicles, our investment programs and our ACO certification program. Through these work streams, the HPC gains unique insights into what hospitals, ACOs, and their partners are doing to transform care in service of a range of goals, from cost containment to addressing health disparities. Bluntly, we get a bird's eye view of promising practices, cross-cutting themes, issues, and interests among our ACO applicants and investment program awardees, and I think we can reasonably assume by extension to other providers. So the truth is we capture quite a bit of information, but obviously some of the value of what we learn is lost if we keep it to ourselves, rather than sharing our findings more broadly, not only among ACO applicants and investment program awardees, but with the community more broadly. And it's for that reason that we have a learning and dissemination strategy. Next slide, please. When we talk about learning and dissemination, what we're generally talking about is the process of harvesting information from our work, packaging it for consumption in various forms, and distributing it to different stakeholders. And we do this work in service of 5 major objectives. The first is obviously to advance care delivery transformation by spreading promising practices and sharing lessons we've learned. The second is to promote awareness of HPC certification and investment programs, their impact and successes, and from time to time, some challenges. The third is to foster relationships with and among awardees and other Massachusetts providers. The fourth is, when appropriate, to inform policy both locally and occasionally nationally. And the fifth is to fulfill our public and statutory responsibility to evaluate our programs and share what we learn. Much, but not 100% of that work of achieving these objectives is handled by our learning and dissemination team. So for a deeper dive into what we're doing and what it looks like, I'm going to turn it over to our Associate Director, Vivian, to tell you more.
Thank you, Kelly, and good morning, Commissioners. Before I dive in, I'd just like to note that while you may usually hear about our learning and dissemination activities through the new and upcoming publication slides, this is the first time that we've presented on this topic at CDT. So I'm particularly excited to share our approach and to get your feedback today. I'd also like to take this opportunity to acknowledge my colleagues who support this work, Jasmine Bland and Hadassah Charles. I'd like to start by sharing the way we think about our learning and dissemination activities through which we achieve the objectives that Kelly just outlined. The 4 buckets of activities include promote, convene, educate or inform, and advocate. And as you can see, each type is geared towards a different audience. Initially, we focus primarily on outputs in the promote bucket in order to build awareness of HPC certification and investment programs. We did this by ensuring that every HPC certified ACO and awardee had a profile containing key facts about their approach, and that every investment program had an impact brief with an overview of the program and, as the name suggests, its impact. Over time, we've shifted our focus and invested more resources into the educate and inform bucket of outputs through which we share insights from our programs to help advance care delivery transformation by spreading promising practices and lessons learned. Through resource guides or awardee spotlights, for example, we're able to offer practical tools and considerations as other provider organizations explore implementing similar programs. We also have the ability to organize convenings in order to facilitate knowledge sharing on priority topics. And lastly, we're able to utilize our outputs to surface barriers or challenges that awardees and ACOs are facing and to make policy recommendations as appropriate. The next slide offers an overview of our investment programs to date. I won't go into each of these in detail, and instead we'll use this as an opportunity to make a plug to visit our website and learn more about them. But what I will note is that our investment programs are heterogeneous and vary widely in terms of their size, scope, and areas of focus. They run the gamut from CHART, which included nearly 70 million in investments across 30 community hospitals to support delivery system transformation towards value-based care, to Beside, which is much smaller and more narrow in its focus of supporting 2 hospitals implementing doula services to improve the care and care experiences of Black birthing people. And then there's everything in between. Our investment programs have supported innovations in a number of critical areas, such as increasing access to behavioral health care, promoting use of telemedicine before the pandemic necessitated its use, and addressing patients' health-related social needs. While some of our investment programs have ended, we continue to use their data to generate valuable insights that remain broadly applicable to other provider organizations. And as our investment programs have evolved over time towards more specific areas of focus, we've also adjusted our learning and dissemination approach to accommodate different goals, different audiences, and different kinds of learning. In the next slide, I offer an example of the portfolio of outputs for one of our investment programs, the Mother and Infant Focused Neonatal Abstinence Syndrome, or NAS, investment program. This program is a great example because it really enabled us to do so many things in each of the 4 buckets of L&D activities. As we work closely with the program team to generate ideas on topics that would be high impact and for which we had enough content to support the development of an output, we focused on 2 main topics. The first topic centered on reducing stigma for people with opioid use disorders and their families. For this topic, we did a presentation at Academy Health, and we also created a resource guide with practical strategies and tools for reducing stigma. For example, one strategy to reduce stigma is bringing lived experience to the care team by hiring peer moms. In the resource guide, we use both data and awardee insights to demonstrate the value of peer moms, and we also provide a sample job posting from our awardees. The second topic we narrowed in on was spreading the use of non-pharmacologic interventions, such as use of mother's milk, rooming in, and skin-to-skin contact to improve outcomes for infants with opioid exposure. To do this, we created a DataPoints describing the different types of non-pharmacologic interventions and how they were associated with improved outcomes, such as reduced length of stay. And we also developed a video in collaboration with Penguin, or the Perinatal Neonatal Quality Improvement Network, featuring one awardee's experience implementing these interventions. We continue to work with Penguin to scale these practices at other birthing hospitals across the Commonwealth with funding from the State Opioid Response Grant. And through that partnership, we also support semi-annual Penguin summits that build on this work. While this program may be the poster child for what we can accomplish in L&D, our aim for every program is to develop a portfolio of assets that hit different audiences with different interests and learning styles. Next slide, please. I'll now shift gears and talk about some of the learning and dissemination we've done for our ACO certification program. It's worth noting that this program offers a unique window into accountable care organizations across the Commonwealth, and we really have an unprecedented opportunity to provide a snapshot into how they're structured and what they're doing to improve population health. We do this in a number of ways. For audiences interested in learning more about what ACOs are and how they achieve their aims, we developed a set of ACO policy briefs that include a primer on accountable care organizations, as well as details on how ACOs in Massachusetts manage population health and how they manage their performance on quality and cost. For audiences that are more visual, we developed an HPC DataPoints through which we share insights, for example, on how ACOs distribute their shared savings and how they incentivize performance improvement. Lastly, in collaboration with the Massachusetts Coalition for Serious Illness Care, we held a convening on serious and advancing illness care and value-based payment models, which featured 3 ACO panelists, which we were able to identify based on their ACO certification responses. Next slide, please. As you know, the ACO certification program, now called ACO LEAP, which stands for Learning, Equity, and Patient-Centeredness, has evolved over the years. And this last cycle included a new set of standards which embrace the ACO model as a catalyst for learning and improvement. ACO LEAP is structured to allow for a variety of approaches to meet certification criteria. This approach gives us an even better window into some of the unique features of each ACO and better enables us to showcase innovation and enable peer-to-peer learning. We are currently in the process of analyzing the data and generating ideas on what the portfolio of L&D outputs and convenings might include. But in order to inform our approach, the ACO certification team administered a survey of primary application contacts from the certified ACOs and included 2 questions to assess topics of interest as well as format preferences for learning opportunities. Based on the 8 responses they received, you can see that the primary topics of interest include data-driven decision-making, health equity, and population health management. And the preferred formats include webinars, brief written reports or infographics, and multimedia products such as videos or animations. Next slide, please. This feedback on format preferences is consistent with feedback we've received from provider organizations in the past. For this reason, we've developed new types of outputs such as the Spotlight series and videos, and are also exploring topics for HPC shorts and webinars. Importantly, we recognize that in order to maximize our reach, we also need to improve our dissemination approaches. So some ideas that we have for doing this include sending outputs to organizations relevant to the topic of the output and asking that they share them with their dissemination channels. And additionally, we're interested in continuing to partner with other organizations on developing outputs as well as co-hosting convenings. So I'll now turn it back to Kelly to offer some examples of such partnerships.
Thanks, Vivian. We can go to the next slide here. So we wanted to do a little bit of a drill down on partnerships because unlike some of our learning and dissemination outputs, what we're doing behind the scenes isn't quite as visible. So for our purposes, when we talk about partnership, we actually use that term fairly broadly to characterize any situation in which we are collaborating closely with another organization or organizations to advance a goal to support care delivery transformation. Each one of these relationships has its specific nuances, but they generally have some key features in common. The first, and it's probably an obvious one, is a shared area of interest, something where we mutually want to have an impact. And as Vivian already cited, our work with the Perinatal Quality Improvement Network is a really good example of aligned interests leading to many, many opportunities for impact. The second feature is often what I think of as complementary networks. And what that means to me is that we and the parties with whom we're working are able to bring different stakeholders to the table. An example of that, and we've spoken to this group about this in the past, has been our relationship with Mass Challenge Health Tech. So in that relationship, Mass Challenge was representing tech startups interested in developing solutions to improve healthcare delivery. At the HPC, we had an interest in ensuring that thinking was not limited to academic medical centers, and we wanted to make sure that a community voice was present as well. So we brought our network of relationships with community hospitals to the table as well. And finally, the last feature is just generally different skills, perspectives, or expertise. Oftentimes, as Vivian mentioned, we can bring a big picture view. I know here accountable care, looking across ACOs, it's certainly true looking across investment programs. Obviously, we also bring a policy perspective to the table. Frequently, what our partners bring is deep subject matter expertise, particularly around aspects of care delivery where I don't think we would ever claim we are experts. But the point in all of this is that together in these partnerships, we're able to create more value and more impact on a particular area of focus than if we were working independently towards the same goal. Next slide, please. So I just wanted to share a few examples of past and current partnerships in support of care delivery transformation. I'm not going to dwell on the advanced illness care webinar only because Vivian already spoke to it, but it is a really nice example of this notion of surfacing an opportunity, through our certification process, reaching out to an organization with deep subject matter expertise, and then working together to package those two things to bring value more broadly. In addition to what I just described in terms of our broader relationship with Mass Challenge, we've also identified with them in 2021 a shared interest in using technology to advance health equity. Through that shared interest, we collaborated on a health equity event series that brought together HPC stakeholders with Mass Challenge stakeholders to address areas of shared interest. And in that process, we were able to feature some of our awardees and some of our stakeholders in speaking to areas of interest around health equity. Most recently, and where I'm going to dig a little bit deeper, is that we have collaborated with the Brookline Center for Community Mental Health, a past awardee from our Targeted Cost Challenge Investment Pathway, otherwise known as TCCI, of our Healthcare Innovation Investment Program, with the goal of supporting a dialogue around care for patients with complex medical, behavioral, and social needs. Next slide, please. So just for a little bit of context, last year, the Brookline Center's Healthy Lives program, which received funding through the TCCI investment program, was one of 6 organizations in the nation to be selected by the Camden Coalition's National Center for Complex Health and Social Needs to host a regional convening. The project was aimed at addressing the fragmented, siloed landscape of complex care management services by bringing together representatives of care management programs to share ideas and experiences, lay the foundation for a learning community, accelerate the rate of program improvement, and promote adoption of emerging best practices. I want to pause here for just a second to note that the need for improved care for patients with complex needs has arisen directly or indirectly as a theme in several ACO investment programs, in several HPC investment programs aimed at improving outcomes and lowering cost. Also, through our ACO certification process, we've seen that ACOs often focus on this population as part of their population health management efforts. So from the standpoint of care delivery transformation, we have more than a passing interest in encouraging continued innovation and learning in this space. After participating in a steering committee that shaped the initial convening in April 2021, the HPC offered to continue to work with the Brookline Center to determine what it would look like to sustain this learning community for the longer term. The result has been a series of quarterly events focused on different aspects of care for patients with complex needs. The Brookline Center has, by design, been very much in the forefront of these events. But the HPC has offered, I hope, some unique value and support. The first is in terms of thought partnership. As I've mentioned more than once, we do bring a perspective on areas of opportunity and interest that can't always be, that are unique to our sort of overarching view of both the ACOs and our investment program awardees. So we've been able to use that expertise to help shape agenda topics and generally design, help to architect the focus of these events. The second thing we've brought is access to our awardee network. Throughout this process, we have used our network of relationships to identify local experts in complex care management who are willing to bring their experiences to the conversation as panelists or presenters. And finally, we've been able to offer some general hands-on skills. Executing these kinds of events, even remote ones, takes coordination and project management, and we've been able to help out there. So I would be remiss if I didn't stop right now for just a second to acknowledge the incredible partnership and leadership of Henry White and Jay Smith at the Brookline Center, and also a lot of the hands-on work contributed by Becca Schwartz from the team at the HPC. We are now heading into our third virtual event in June with a fourth one planned for the fall. So I hope this gives you a sense of some of the things we've been working on as part of our learning and dissemination effort. But in the spirit of learning, would appreciate hearing any ideas from you about what we've done so far, what we might do or not do in the future. So we have a couple of general questions on the next slide, but are happy to hear any feedback you have to offer.
Kelly, thank you for a great summary of the work that's going on more behind the scenes than we normally get a chance to discuss. Are there thoughts or comments either on the questions that are on the screen or in general? While you're thinking, we have the opportunity. Lauren has joined us. Welcome, Lauren. We're glad you're here. This allows us to return to the minutes. So while you're thinking about that, may I have a motion to accept the minutes?
So moved.
Thank you, Marty. Colleen, I believe we're ready for a roll call.
Absolutely. Thank you so much. Starting with you, Chair Blakeney.
Yes, aye.
Commissioner Cohen.
Aye.
And Undersecretary Peters. Lauren, did I get an aye from you?
Yes. Is my audio working? Yes.
Okay. Thank you. All right, all set.
Okay, thank you. You've had enough time to think now, as Stuart, as David mentioned earlier, no more stalling. What are the thoughts here?
Barbara, I'll be happy to weigh in. I think the framework that Kelly has outlined is wonderful, and I think it goes to something we've been talking about for a long time, which is how do we really disseminate what we're finding, both from the investment programs as well as the certification programs. So I think it's great. I think the question is how do we find the right audiences? And, I was just thinking, the Brookline, what you're doing with the Brookline Mental Health Center is wonderful. They have such a great expertise and history in this area. But, how do others get the opportunity to join in as you're putting those networks together? And do we make it simple for organizations to reach out to us about their desire to be part of those learning communities?
Yeah, I think it's an excellent question, and it's one that we spend a lot of time thinking about, both in terms of how we push what we're doing to different audiences, and that's, I think Vivian could talk at length about all of the ways we think about figuring out where to push. But I think also there's a bit of a pull aspect to this too, that ensuring that organizations are aware that we are interested in learning what they're doing, thinking about how we can partner, thinking about how we can work together to just, as I said, advance shared goals. So as I said, we would be very, very interested, and obviously in hearing from any of you, in that you all have networks and you all have relationships and awareness that probably we don't have. So would very much be interested in those perspectives. I think I saw a hand up.
Mm-hmm. Stuart. And then Dawn.
You're on mute, Stuart.
Being so articulate with I want to take something from your playbook, Don, and that is, I think it would be great if the rest of the country knew a little more about what we're doing while we're learning about others as well. And I'm wondering whether either the staff at HPC or working with some academic that you have confidence in could put together an article that talks about this whole process that we've been engaged in and over these last several years in terms of promoting ACOs, improving quality, getting greater equity and so on, and make it available in some national journal. Kelly, is that something that you guys might want to think about in the future?
I think we would absolutely think about it. I think that, as I said, there is what I had not thought about, but it's an interesting idea, is sort of thinking holistically about not just the work that we do, obviously, across the HPC, but then the process of sharing that work. It's a very interesting idea.
Just think about it. Okay.
Thank you, Stuart. Don.
I second Stuart's point. I was going to make a point about getting this stuff into publication.
You see that?
Right with you, Stuart. I think maybe it's a process question, Kelly. What kind of process could be set up that would be an engine for publication? This is just too good to hide. I have one other thought that just came to me as you were talking. What we're approaching about 10 years. What about a real big event, a kind of hosting an event? We could do it virtually or maybe even in person, called 10 Years of Learning or something, where we went back over this history of all of the grant programs, harvested lessons learned, did some follow-up testimony from places that did get support, scientific testimony on progress that we made. I think it's time to celebrate. Maybe that would be something to, since the staff have such a large amount of spare time, I thought I'd add that to the.
Well, we always like to celebrate, so that's a good thing. So
like a big thing, yeah.
Yeah. So I take your point that maybe there's a moment to be seized here to sort of, again, look holistically at work we've done. I also want to respond to your point about sort of paths to academic publication. In some cases, those paths have existed and do exist. And I'm going to give you a sneak preview of something that I hope we're going to be discussing at an upcoming board meeting, which is the evaluation of our shift care the OUD track of our shift care program. That has been done in collaboration with Brandeis, with whom we contracted to evaluate the program. And we have done that in other circumstances as well. So in some cases, we take that path and we go sort of the publication path. As Vivian said, as we also think about sort of learning and sharing learning and promoting what we're doing, that's taken us kind of down, to use a term we use internally, towards more easily consumable content. So I think it's a bit of a mix of both, right? So we have our evaluation work that's quite extensive. That's oftentimes the source of our more focused, sort of contained, digestible work, but both play an incredibly important role. All right. Well, so with that, I will say thank you. These are a lot of really, really good ideas. And as we continue to develop this strategy and work with David and Colleen on how to get the word out, I'm sure we'll have more to say to you in the future. So I am going to keep talking. I apologize for that, but I'm going to shift us to our next agenda item before I turn it over to Catherine Harrison. We can go to the next slide, please. So, as you know, the HPC has made a commitment to applying an equity lens to all of its work and to using all 4 of its strategic levers to contribute to the effort to advance health equity in the Commonwealth. As we've explored what it'll take to achieve this objective, one of the things we've come to appreciate is that each of these levers offers different opportunities and constraints as we pursue health equity. Therefore, as we've turned to implementation, each of the teams has had to adapt its approach to their specific work while remaining true to the agency framework that you've seen. So while there will be an update on the broader agency agenda this summer, we thought it would be valuable for the Care Delivery Transformation Committee to have a bit of a window into how we're working on health equity, specifically in the context of our care delivery transformation work. So that's what we're going to offer to you today. Next slide, please. Okay, so just for context, when we talk about our care delivery transformation work, what we're talking about is the things that we do that generally fall into these 5 buckets, some of which we've talked about today. So obviously our ACO certification program, our investment program, our partnerships, the learning and dissemination function, and our evaluation work. So when we challenge ourselves to apply an equity lens to care delivery transformation in our work, what we're really talking about is how we formalize the approach to thinking about how we will integrate and health equity into all of these work streams, and then sort of in a mirror image of that, how we will use these levers to influence health equity in the Commonwealth. So to introduce how we are doing that, let me turn the presentation over to Catherine Harrison, the Associate Director of the Healthcare Transformation and Innovation Team.
Thanks, Kelly, and good afternoon, commissioners. Nice to be with you. Next slide, please. Okay, so as we approached this question of what would it look like to apply a health equity lens to the HPC's care delivery transformation work, we started to recognize a few potential challenges or areas of need. So first, applying a health equity lens, it's a very broad idea. And given that there's quite a bit of heterogeneity in the care delivery transformation work that we do, as Kelly was just showing on the previous slide, we recognize that applying a health equity lens could look very different from one care delivery transformation project or program to another. So one thing we realized we needed was a common understanding of what counts, if you will, as health equity work. Where and when in the course of our work do the opportunities exist to apply a health equity focus? What exactly are we trying to change? Are we trying to look at and change the care delivery experience of individual patients? Are we looking to change the culture or practices of institutions like healthcare provider organizations? Or, is it only truly health equity work if we're trying to get to root causes like, the social determinants of health or other structural forces at play? We also had to think about what kinds of levers or influence does the HPC have in the context of our care delivery transformation efforts? What are the interventions that exist that are at our disposal to affect change? So with all of those questions, we felt like it would be important to have some kind of process or framework, a conceptual framework, if you will, for really looking at what are our options and being able to help us make some choices in at least a somewhat rigorous way. So that was one area of need that we recognized. We also saw that if we really want a health equity to be a key feature of the content of our work on an enduring basis, it also needs to be built into the fabric of how we do our work. So we agreed that some standardized tools and processes were going to be really important to bring some consistency to our approach, meaning, really to make it so integral that we couldn't not do it. And so finally, we also identified a real need to make sure we understand the expertise that already exists in the health equity space. And since it hadn't been a fully intentional or explicit area of focus for us in this body of work previously, we really recognized a need to build our own knowledge in this content area. Next slide, please. Okay, so it was with those goals in mind that we've taken a few specific steps forward to address one or more of those needs. And these are the 4 that I'd like to share some details about with you today. So I want to start by telling you about a tool that we've developed for thinking and talking about health equity opportunities in our work and helping us make decisions about how we'll apply that health equity lens and address health equity in each of our projects. We call this the Equity in Every Project, or EAP tool. We're also looking at how we can bring equity principles into our stakeholder engagement process. So I'll talk about that a little bit. And then I want to briefly touch on a couple of other pieces, a quarterly review process that we've put in place to help us stay accountable to our and the agency's overall equity commitments. And finally, a collection of resources that we're developing to further our learning. Next slide, please. Okay, so starting with the Equity in Every Project tool. So we call this a tool, but it really is just a process. It's a set of steps, the purpose of which is to help us explore and define how we will address health equity within a particular care delivery transformation project. And this goes back to some of those big picture questions I laid out earlier when I was talking about the need for a conceptual framework and teeing up things like, what does it really mean to apply a health equity lens in the context of care delivery transformation work? And where do the opportunities exist for us to intervene? So this process or tool that we've built leads the project teams through a series of steps that help answer those questions and ultimately help us produce a decision about what the health equity focus will be for any particular care delivery transformation program or project that's in the HPC's portfolio. So this slide is really just an overview of the steps in that tool. The actual tool, of course, goes into some more detail and gives the users a little bit more guidance, a set of questions to really walk teams through those steps. But at a high level, I'll just talk about this briefly. We first start by trying to understand the health inequities that may be most salient to the particular area or topic area of a project. So, for example, a project might be focused on maternal health, substance use disorder, or even something less specific like the care delivery practices within ACOs. What are the most important health inequity issues or health equity questions that come up on topics like those? And we try to explore by reviewing the literature, of course, talking to experts and stakeholders, and really seeking to get a broad sense of the equity issues at play. And I will note here, we take seriously the need to consider that the equity issues that we think may be the most important based on our perspectives and previous experience may not be what others experiencing those inequities or others with deep equity expertise might name as the most pressing. So a really important goal here is to open ourselves up to perhaps learning or hearing about issues that we didn't know existed and allowing those ideas to influence our thinking about where we'll focus for the project. The second step we're calling Explore, and this is a phase where we try to consider what we've learned about the relevant health equity issues and really try to think about what are we going to focus on as the core issue in this particular project. Where is the inequity occurring that we're trying to change? And how do we expect this particular program or project to affect change? So we consider the levers or the influence that we might have in, for example, a certification or a program or an investment program or an L&D or evaluation project, and consider where can we bring those levers to bear in this context. And I want to talk about this a little bit more on the next slide to share with you exactly how we do that. But before I get there, I'll just finish this out. Once we've kind of laid out some options and made a decision, the next step in the tool is to think about things like feasibility, potential for impact, and incorporate those into our decision making about the health equity focus. And finally, we write this up in the form of a brief health equity aim statement to help us put down in words exactly what the inequity is that the project will seek to address and how we'll do so. Next slide, please. Okay, so as I just mentioned, the step in the EAP tool that's about exploring and considering the options for how a particular project will incorporate a health equity focus. This is a framework that we've begun to use that you see here on this slide to help us think about that. Think about how are we going to define the health inequity for purposes of this project, and what is the intervention or lever that we'll try to use to address it. So let me just try to orient you a little bit to this. The horizontal axis of this grid represents the question, where is the inequity occurring that we intend to tackle in this project? In some of our work, like for example, in our investment programs, we are commonly interfacing with teams of clinicians and staff who are implementing, for example, a new care model. And in that context, it might be that we want to define the health inequity or the issue as occurring at an individual or interpersonal level, as in what's happening between a patient and a clinician in a particular encounter. In other work that we're doing, for example, in ACO certification, we're tending to think about ACOs as an institution, which you might locate a little bit sort of in the middle of this horizontal line or in the middle of this grid. And for that reason, we might name the inequity that we're trying to address a little bit differently. And then on the very right-hand side of the axis, we might ask, do we have the opportunity in this project to see and define the inequity from a more systemic or structural perspective as an issue that transcends any particular care delivery context? So that's kind of what this horizontal aspect of the grid helps us grapple with. On the vertical dimension, what we're trying to look at here is what are the options within a given project for the type of intervention we'll undertake, or what lever we will try to pull to try to affect the issue. And commissioners, I know you're familiar with the concepts of interventions that are, relatively speaking, downstream, midstream, and upstream. We have used that language before. We use those ideas to distinguish between work that is intended to address or blunt, if you will, the effects of an inequity on individuals or address the needs they create, which is sort of the downstream space, versus work that is intentional, political, economic, or other environmental contexts in which the inequity is rooted. So when you put those two dimensions together, you get this grid with 4 quadrants that offer a framework to create some options for defining the nature of the inequity that we want to tackle in a given project and how we'll approach doing so. And I hope if this has become a little bit too conceptual, that the examples we've tried to populate here on this slide help illustrate this a little bit more concretely. I'm not going to say a lot more here, but let me just leave you with 2 thoughts about this grid. So first, the purpose of using this framework is to really help us organize our thinking and see the options for how to address health equity within a project. We do not go into this thinking that there is a single right answer, nor do we look to this tool to tell us what we should do. As Kelly has commented to me, this is not an algorithm where we're trying to put in inputs and expecting it to spit out an answer for us. But the thing that we do find valuable about it is that it kind of forces us to get clear on what it is that we're hoping to accomplish and how we intend to do so. And that just feels vitally important in a space that otherwise could get very complex. Second, we are not bringing at this stage a value judgment about where we should be doing work, or where in this grid or in which quadrant our care delivery transformation work should be focused. Again, the grid helps us seize options and opportunities. And I think it helps us understand that there's likely to be valuable work to do on health equity, almost no matter what quadrant we're in, whether, in some cases we have the opportunity to do really upstream policy level work, or focus on changing or improving the downstream care delivery experience, which, we have, which is equally important. So I think using this grid over time will help us both identify the kind of work we're doing, where we're doing it, and potentially, we may be able to use it to construct some strategy, either to really focus on 1 or 2 areas where we seem to have the most strength, or, for example, to notice gaps and think about how we might focus in different areas than we have before. So finally, I do just want to credit some of our colleagues at the Department of Public Health who shared this framework and these ideas with us. And there are several organizations behind these ideas that originated and developed them, including the Racial Equity Institute. Next slide, please. All right, the last thing I'm going to say about this tool is that we plan to use 2022 as a pilot year. We know this is an imperfect framework, and we're looking to give it a shot, give it a try with some of our programs. And we're committing that each of our care delivery transformation program teams will pilot this in some way in calendar 2022. So here are a few examples of how we've already begun to do so. For example, in our birth equity and support through the inclusion of doula expertise or beside investment program, commissioners, you know, this started off with a very intentional health equity focus on expanding access to doulas for Black birthing people. We're using the tool to help plan how to use some funding that's left over after our investment awards to further the work in that space. We're also piloting the EAP tool in the cost-effective coordinated care for caregivers and substance-exposed newborns, or C4SEN investment program, to shape the topics and overall design of the collaborative learning opportunities that we're planning for that cohort of awardees. And in ACO certification, partnering with our L&D colleagues, we know we have the chance through that particular L&D lever to really focus on health equity activities among our ACOs. And we'll be using the EAP tool to help us define how we might support ACOs in advancing their health equity work. Okay, so that kind of completes the first item that I wanted to cover with you. Now I want to tell you a little bit about the work that we're trying to do to bring an equity lens to how we engage stakeholders to inform our care delivery transformation work. And here I also want to acknowledge my colleague Taylor Jolly, who's joining me in these efforts. So I think you all understand what I mean when I use the term stakeholder engagement, but just to be clear, what I'm referring to is the process we use to intentionally seek input from external organizations or individuals into the design, implementation, or evaluation approach of a care delivery transformation program or work stream. Stakeholder engagement is one of those foundational things that we do to inform our work. And we feel if we're serious about ensuring that health equity is embedded in what we do, as I say, we thought it was important to examine how we get there, including whose perspectives we make ourselves open to and in what ways. So this slide captures why we think examining our stakeholder engagement process is important, and articulates a series of goals for this work. We feel if we focus on adopting a stakeholder engagement process that is open to perspectives and ideas that haven't typically been part of the dialogue, that it will make our work stronger by ensuring that it is based on the best available evidence and knowledge, as a result of which we think we can increase the impact of the HPC's care delivery transformation work in promoting health equity, which ultimately supports the agency's goal of fostering greater health equity in the Commonwealth. Next slide, please. So here are some of the key questions that we're trying to explore as we review our stakeholder engagement approach. First and perhaps foremost, we're really taking a look at who we work with and who helps inform us. What types of organizations and individuals do we most often look to and hear from? Speaking of individuals, we're also challenging ourselves here to think about what responsibility we might have to try to hear the perspectives of people, individual residents of the Commonwealth, patients who are ultimately affected by our work, even though we may not think of ourselves primarily as a consumer-facing agency in the way some other state agencies are. We're also thinking about the methods that we use for getting input from stakeholders, from written comments, written opportunities like public comment processes, or formal requests for information, to meetings that we take with different organizations, and considering how do those approaches advantage or disadvantage different organizations or perspectives. We're also asking, how do we make sure that engaging stakeholders is not a one-sided transaction where our work benefits and we've done all the receiving, we've been on the receiving end of all the assistance, and the other person or organization, is either kind of left neutral or even worse off potentially in terms of time, resources, or personal energy or attention, particularly if we're talking about looking for perspectives based from people with lived experience of inequities. Next slide, please. So there are a couple of specific things that we're doing to start working on this area. We've taken an inventory of our current approach to stakeholder engagement and really kind of tried to catalog the organizations that typically engage with us, how they do so at what stages of our current projects in order to identify patterns and gaps. And in addition to that inventory, we've also reached out to some external organizations who we think might have some good advice for us about bringing a health equity focus into our stakeholder work. We've had a good handful of conversations so far, and we've done quite a bit of work on that inventory. So between those two things, we're starting to identify some themes that are captured on this slide. I will say we're still very much in the midst of this work, so this is a very early take on what we're seeing, but I think it will give you a sense of where we might be going. So for one thing, we're definitely seeing from this work that we have plenty of opportunities to broaden the range of stakeholders with whom we engage. We also have heard a lot from folks we've talked to about this idea of the value of building a real network of organizations that we have a relationship to, who might play at different levels, and who might have an easier time accessing sort of grassroots perspectives than the HPC might, but who might become trusted partners for us in conveying and relaying some of those needs to help us ultimately become informed. And I won't go through all of these, but the last thing I'll highlight here is just the general theme we've heard, to start thinking about stakeholder engagement as really relationship building on an ongoing basis, and to have a real sort of consistent feedback loop rather than a time limited thing or one step early on potentially in a process. So these have been really rich and meaningful conversations so far. And as our work continues in this area, our intention is to try to identify some recommendations for steps that we can take to make our stakeholder engagement efforts more equitable within the next few months. Okay, next slide, please. I just have two more action steps that I want to highlight briefly here. And this one is a new series of meetings that we've put together to really make sure that we are holding ourselves accountable and supporting each other to meet our health equity implementation goals. So this is a quarterly health equity review meeting, as we're calling it. And I said this has two main purposes. So one is an accountability purpose. We use this as an opportunity to review our progress against our commitments and expectations. And all the staff that are involved in doing our care delivery transformation work are included in this conversation. We're trying to think about accountability as, not in a traditional hierarchical sense, but recognizing that the responsibilities to contribute and try to ensure that our work is as strong as it can be in this area are shared equally across all staff. Of course, these meetings are also about sharing lessons learned from one work stream to another so that we can improve. Okay, next slide, please. And lastly, I just want to tell you about this sort of set of resources, or if you will, a kind of informal library that we're gathering and sharing amongst ourselves to support this portfolio of work. The goal here is just to put some research papers, articles, other kinds of materials and online resources into a format that's more readily at our fingertips, that folks can use as a starting point when we need to learn more about a particular topic related to equity, and especially to help as the first place to turn during the learn phase of that e-tool that I mentioned earlier. I want to be clear, at the moment, this is not a highly curated set of materials. We don't have formal, ways of deciding what's included and what's not. It's a little more opportunistic at this stage, where we're just trying to capture things as we see them that we think might be helpful. But we still think that there's some value in that it gives us a good starting point for accessing content when we need it. So I am going to more or less stop here. I have one final slide. If you'll go, yeah, thank you. So I do just want to say thank you for hearing this. And if nothing else, I guess what I'd like you to take away from this is that when it comes to applying a health equity lens to the HPC's care delivery transformation work, we really are trying to do this carefully and seriously. And I would say that as we go forward, we're really holding two conflicting things in our hands at the same time. One is we really take seriously that health equity work done in an ill-informed way may do more harm than good. And that if we're really going to do this, that we have to make a commitment to doing it well, just like, you know, across all of the HPC's work streams, we are committed to doing them well. At the same time, we're also mindful of the urgency to take some steps forward and not be paralyzed by complexity. So we absolutely expect to make some mistakes, and the tools and processes that we're trying certainly are not perfect. We know that our work will be iterative, that we'll make adjustments as we learn. And if you have recommendations or suggestions for us commissioners, we're very interested to hear them. So thanks. And although I regret we don't have more time, I'll be happy to take any particular questions that you might have. And of course, happy to continue the conversation offline as needed. Thank you.
Barbara, you're on mute. I think she's.
Thank you.
Okay.
Thank you. Catherine, thank you so much for that presentation. The work is outstanding, even if still in its infancy, and I know that we'll all benefit from the thoughtful approaches that you've taken to create the good foundation that we need going forward. I cannot see all of you. I've lost power here. I have no idea why, but if there are questions, Colleen, could you help facilitate them?
I'm happy to help. Chair Altman has his hand raised.
Yeah, well, this was great. And I don't know who this is aimed at, but when we think about equity or the extent to which different populations are either well-served or not well-served, I wonder whether we could become more strategic's not the word, more focused. I keep thinking back to Sarah's presentation early on this morning, where she talked about the 5 income groups in terms of their access to care and how they changed over the pandemic. And while she didn't focus on this, what we saw was that the group that either had the best or in some cases was often the second highest income group, not necessarily the first. So, you know, when you think about certain services, it may turn out that the lower income people sometimes do better than what we call the near poor or the people who are too wealthy to be in Medicaid, but have very poor health insurance. So what I'm really thinking about is when we talk about equity, or we really at some point need to become more sophisticated in terms of what we mean. And it may be different for different kind of services or different kind of geographic areas. So I'm wondering, as we think in the future, whether we can begin to sort of become more strategic's not the word, more nuanced in terms of how we talk about equity or availability. One last area that really is troubling me now a lot is nursing home care. And there it turns out, you know, we could focus only on low income, but the truth of the matter is that in many cases, the groups that are the worst in terms of equity are the lower middle class who don't qualify for Medicaid, but don't have the resources to buy it themselves. So anyway, I'm just sort of thinking about this broad issue of equity and availability of services and quality.
Thank you, Stuart. Insightful things to consider as we move forward. Colleen, are there any other questions?
I don't see anyone else, Madam Chair.
Okay, well, I want to thank the staff for their very thoughtful process in putting together a program meeting today that's a little bit different, but I think serves us very well in our foundational work. I think we have some exciting possibilities, especially about establishing the foundation for equity. And I think we've got exciting possibilities when we talk about dissemination of knowledge. And I was rudely interrupted by my power outage when I was supporting Don Berwick's suggestion of having a celebration because you all don't have enough to do. But it's worth thinking about how we really celebrate what we know and how we disseminate it. So things to think about going forward. And with that, David, I'm going to turn it over to you for your concluding remarks.
Thank you, Madam Chair. Thank you, commissioners, for a great morning and early afternoon. Colleen, did you have one last thing you wanted to share?
I was going to say we definitely got scooped by Dr. Berwick, but we do have a lot planned for our 10th anniversary that we were planning on talking about at our next board meeting. So watch this space, as I like to say, way too often. And no, that was it. David, take us away. The next meeting is October 12th of this year. So we have a very busy summer planned for you all, but the next committee meetings will be in the fall.
Okay. Thank you all. David, are we done?